Good morning, everyone. Good morning, ladies and gentlemen. Welcome to the second day of the Belvis Symposium. We have today, again, the same distinguished faculty participating and leading the discussions. We are now going to get started with the session entitled Mitral Valve Disease. And with this, I would like to introduce the first speaker, who would be connecting from London. Hello, good morning, Dr. Rajani.
Good morning.
Good morning, welcome here. And it's a pleasure to announce you as the first speaker to talk about the imaging planning for complex structural mitral valve interventions. Thank you, floor is yours.
Thank you very much. So first of all, many thanks for the invite to talk at this fantastic symposium. And I'm really sorry I couldn't be with you this morning. But what I'm going to do over the next 15 minutes or so is to talk about advances in CT planning for transcatheter mitral valve replacement. My name's Professor Rajani. I'm a consultant cardiologist and a professor of cardiovascular imaging based at Guy's and St Thomas's in London and also King's College Hospitals. So these are my conflicts of interests. So why transcatheter mitral valve replacement? So we know that moderate to severe mitral valve regurgitation occurs in approximately 2.5% of those individuals greater than 65 years. 12% in those patients following a myocardial infarction, and 24% of patients with systolic heart failure. Mitral valve regurgitation, even mild mitral valve regurgitation, results in a twofold increase in death and rehospitalization. And we can see that from the COAPT and MITRA-FR data that there is a 35% mortality at 2 years in the MITRA-FR study, and in the COAPT study, a 55% mortality at 3 years. Now, despite all of these startling facts, only 5% of patients actually undergo treatment. So we know how to evaluate severity using the ESC guidelines and also the ASC guidelines. And I think the most noteworthy point from this slide is that there is some variability with the European Society of Cardiology and the American Society of Echocardiography in how we grade significant mitral valve regurgitation. And this slide simply serves as a reminder. Now, medical therapy should be the first port of call in patients with secondary mitral valve regurgitation, and that includes ACE inhibitors and conventional therapy such as beta blockers and cardiac resynchronization therapy. And the reason being is that medical therapy can reduce the severity of mitral valve regurgitation in approximately 40% of those individuals. CRT can reduce mitral valve regurgitation, but there is only a 50% response rate. Now, when we look at the guidelines, both the American and European Society of Cardiology guidelines really indicate that transcatheter mitral valve replacement or surgical mitral valve replacement or repair should only be considered really in those patients who have myocardial ischemia or who are undergoing revascularization and in whom those patients have failed medical therapy, including cardiac resynchronization device therapy. Otherwise, we really are in class 2B territory. So what are the barriers to mitral valve intervention, and particularly with transcatheter mitral valve replacements or repairs? First of all, there is a lack of historical evidence, a lack of validated imaging criteria for suitability. Patients are from different cohorts to the structural heart team. There's a poor awareness of therapies, high screening failure rates. It's difficult to identify the right phenotype of patient that benefits, and we need more understanding as to the physiology and the ideal patient. There is currently quite a large competition between mitral valve repair, such as with edge-to-edge repair techniques or direct or indirect annuloplasty techniques versus complete transcatheter mitral valve replacement strategies. So let's now swiftly move on to the imaging planning for transcatheter mitral valve replacements. So I'm going to show you our approach at Guy's and St Thomas's Hospitals in London and also at King's College London. So as we zoom down into London and England, some of the strategies that we incorporate are based on the international literature. Now, for CT planning for transcatheter mitral valve replacements, this would be the standard approach. We would bring out the mitral valve annulus by placing our crosshairs on the 4-chamber and 2-chamber views in the bottom left and the top right-hand image. And on the top left-hand image, you can see that we're able to produce the mitral valve annulus. From this, the mitral valve annulus, we're able to measure the perimeter, the area, the septal to posterior distance, and also the intercommissural distance. And this is the fundamental measurements that we use to determine the size of the mitral valve annulus. Now, the biggest concern with mitral valve replacement therapy is the concept of a neo-left ventricular outflow tract. Now, we know that on the bottom left-hand image, the left ventricular outflow tract is that boundary between the anterior mitral valve leaflet, the basal septum, and also the aortic valve. Once a transcatheter mitral valve is placed in the mitral valve annulus position, you get displacement of the anterior mitral valve leaflet and the generation of a new left ventricular outflow tract, or the so-called neo-LVOT. And this is a potential area of concern as it can result in left ventricular outflow tract obstruction. Now, a number of different factors have been proposed to account for neo-left ventricular outflow tract obstruction, and these are portrayed on this slide. These include device protrusion, device flaring, an acute aortomitral angulation, and also the presence or absence of a basal septal bulge. The other thing that we also need to account for is an acute aortomitral angulation. And this is just a technique of measuring the angulation between the outflow tract and also the mitral valve annulus. And in this example, it was 135 degrees. There is some debate as to what is significant, but in general, the more acute the angle, the more likely there is to be a neo-left ventricular outflow tract obstruction. Other important factors is the height to the left atrial appendage, the height of the left atrium, and the height to the pulmonary veins. And also we need to consider the full morphology of the left ventricle. So we look for areas of scar, calcification, myocardial thickening, the morphology of the mitral valve leaflets, the positions of the papillary muscles, and also the size of the left ventricle. It's also important to look at the size to the papillary muscles from the mitral valve annulus so you don't get impingement of the papillary muscles. And this can be done by placing your crosshairs over the heads of the papillary muscles, as you can see on the right-hand side. Now, also important to date has been the presence of thoracic anatomy. And one of the reasons is that the majority of approaches are currently performed using a transapical approach. A lot of the device manufacturers are now looking and investigating the feasibility of transseptal approaches, which will clearly be more leads. Now, this is one of the world's first images a couple of years ago of a Medtronic Intrepid device in situ on a post-procedural CT scan. And you can see that there are two nitinol frames, an outer nitinol frame on the bottom hand image, which flexes and changes with the mitral valve annulus during systole and diastole, and an inner perimount nitinol frame, which houses a 29mm perimount valve. So with this particular device, you get no significant left ventricular outflow tract obstruction, no flaring, device protrusion. It conforms to the mitral valve annulus, and there's a low risk of leak. One of the major issues that we have in terms of neo-left ventricular outflow tract obstruction, which is a highly cited issue with transcatheter mitral valve replacement, is that there is a variable definition in the literature. And one of these issues is really that people are defining a neo-left ventricular outflow tract obstruction as an anatomical reduction in the area of the outflow tract, when all of us, I think, can appreciate that actually outflow tract obstruction is a physiological phenomenon. Now, a couple of years ago, we also investigated as to whether or not it was possible to actually model physiology from pre-procedural CT data sets. And we published a couple of years back our first approach of doing this using a pre-procedural CT data set and also a baseline transthoracic echocardiogram. Now, using pre-procedural imaging data in computational fluid dynamics, we're able to demonstrate that we can actually measure or simulate the anticipated peak and mean gradients in the left ventricular outflow tract following device deployment. And this correlated very well with the actual gradients actually achieved after device deployment. This was then extended to a further series of patients, and this just demonstrates how we do this approach. We use the CT anatomical data, put in some input and output boundary conditions about the LV geometry, mitral valve annulus, the aortomitral angulation, also some echocardiographic data from the procedural data set, and from this we were able to derive flow and 4D flow from cardiac CT. This technique can also be used to look for residual volume and residual blood particles in the left ventricle to predict whether or not there is a risk of subvalvular thrombosis. Now, we've since forwarded our techniques and developed this further, and this just shows how complicated this can be to actually perform this type of technology. But it requires us to perform image segmentation. Image segmentation is followed by surface processing. Following surface processing, we do motion tracking. We perform sensitivity analysis, and we then implant the virtual valve into the CT dataset mesh. Once this is done, we merge this with the LV cavity. We input boundary conditions. We create a CT mesh. We use a number of different physics solvers, surface mapping, morphing, and then we also perform flow field analysis using advanced physics solvers. Now from this, we're able to produce beautiful images of the left ventricle using computational fluid dynamics. And apologies if the streaming rate is quite slow, but essentially this is looking at blood particulate flow in the left ventricle, which is simulated from pre-procedural imaging datasets to try and predict whether or not a patient is likely to get subvalvular thrombosis, to look at left ventricular wall stress, and also to predict procedural outcomes. Now, another thing that we also do is imaging for the valve-in-valve procedures. This is just a brief video of what our current approach is for valve-in-valve therapies. So this is just the example of the case. We can see from the transthoracic echocardiogram that there is severe LV dilatation and an abnormal orientation of the bioprosthetic mitral valve to the interventricular septum. This was a degenerative 27mm perimount, which had been in situ for 17 years. Now you'll be able to see that clearly the LV cavity is very small. The left atrium is particularly large, measuring about 750 milliliters. And the concern is that there was abnormal angulation of the mitral valve to the interventricular septum, which caused some concerns to the interventional cardiologist in terms of device deployment. Now, the patient had a significant mitral valve regurgitation and also stenosis. There was mild tricuspid valve regurgitation and also evidence of compression of the right atrium. So these are some 3D cinematic volume rendered images which were created from the CT dataset. And you'll see that using modern CT techniques and cinematic volume rendering, we can obtain beautiful imaging and renditions of the cardiac anatomy. And this just highlights some of the key anatomical features. Using this technique, we can also portray the left ventricular cavity and the various anatomical structures using cinematic volume rendering with transparent rendering imaging to look actually from the back of the left atrium onto the bioprosthetic mitral valve to provide a detailed anatomy of this particular patient. We also use cardiac CT endoscopy, so using the cardiac CT dataset, we're able to move down from the left atrium, down through the bioprosthetic mitral valve to show the interventional cardiologist the approach of the catheter. We're now going to angle down to the left ventricle and also look up to the left ventricular outflow tract. Now, we also do all of our planning using CT, and I've shown you some of the basic techniques, but we now have available with some of our industry partners more sophisticated techniques to do this in a semi-automated fashion. Now, this is one of the platforms which I won't allow to play fully because it's quite long, but essentially what we're doing is that we're using the technique and the software to segment the heart anatomy, to size the bioprosthetic mitral valve, and then to plan the transeptal puncture. Now, from this, we're able to simulate a SAPIEN 3 valve deployment in the mitral valve prosthetic area and to look at neo-left ventricular outflow tract obstruction. And you can see that we're doing the segmentation here on the slide, and we're just verifying the segmentation. Now, once the segmentation is done, we're going to measure the annulus or the bioprosthetic sewing ring size. And from the bioprosthetic sewing ring size, we'll be able to implant any valve that we wish to into this particular bioprosthetic valve that's degenerated and look at neo-left ventricular outflow tract obstruction. And You can see that we're just measuring the internal sewing rim so we can get the true ID of the valve type and size. So once we've measured the size, we're now going to delineate the aortic valve, since this is going to provide some anatomical boundary points for the procedure. And now we're going to virtually implant the valve. And you can see that once the valve is implanted, we can move it towards the left atrium or down towards the left ventricle, because clearly the height of deployment will impact on the neo-left ventricular outflow tract area. Now this essentially is one of the final steps in the CT planning, that we're just looking at the optimal deployment zone. Once the optimal deployment zone is calculated, we'll be able to obtain the neo-left ventricular outflow tract area, look at the optimal fluoroscopic projections for the interventional cardiologist, and then be able to guide the actual procedure itself. What we would also do is to provide detailed planning of the transeptal puncture point, because this is going to be one of the fundamental important factors for the interventional cardiologist to achieve a good result and a good procedural deployment. So here we've just planned the transeptal puncture, and then we will bring up the optimal fluoroscopic angles, which are now shown on the screen. And from this, we're able to derive that the caudal angle would be 48.2 degrees and the RAO 57. Now, what we're also now doing is using finite element modeling, which is a sophisticated computer engineering technique that enables us to account for the tissue properties. And this was just used to see what the device flaring would be. We now also routinely, for our complex cases, use virtual reality. This is an example of the GE prototype, which enables us to provide all of this simulation data towards the interventional cardiologist to manipulate before they're going to use their procedure actually in the cardiac cath lab. So our interventional cardiologist would have a 3D headset, and they'd be manipulating the CT data to understand a little bit better about the anatomy before they're going to proceed. So we do computer simulation also for valve in MAC, which I think is one of the most complicated valve procedures that we do in the transcatheter domain. It's associated with a 50% mortality at 12 months, and so it's important that we get this right. Now, from the CT dataset, we can generate finite element modelings and perform finite element analysis simulation, similar to what you've seen on the FEOPS platform. This enables us to generate neo-left ventricular outflow tract areas while accounting for the tissue properties. So not only the mitral valve, the papillary muscles, the calcification at the mitral valve annulus, but also the geometric properties of the left ventricle. Here you can see that we can virtually deploy a valve in the mitral valve annulus calcification position to derive a neo-left ventricular outflow tract area. So we would reconstruct the mitral valve and look at various heights of deployment from low, intermediate, and high to see what impact this has on the neo-left ventricular outflow tract. We can take views from the left atrium at these various positions, and also views from the aorta at the low, intermediate, and high positions. Now, from these various positions, we would derive the neo-left ventricular outflow tract area, and you can see that there is an exquisite relationship between the height of deployment and the area that you're going to achieve. But clearly, there's no way of us guaranteeing where the interventional cardiologist is going to be able to deploy the valve in real life in the cardiac cath lab. So the advantage of this technique is also that it enables us to model for the calcium behavioral forces, which conventional CT platforms do not enable us to. We can see in this particular example that was unsuitable for a valve in MAC, that there was insufficient calcification to be able to anchor the device. And in this example, we can see that there was a good seal and a low risk of paravalvular regurgitation. Now, this is just an example of the platform. For time's sake, I'm not going to allow this to play, but this is just the type of the platform that you would be presented with that would enable you to manipulate the CT dataset and to derive the neo-left ventricular outflow tract. So what have we done next to ensure that our interventional cardiologists have access to all of our detailed planning? So we're now moving to us being in a situation where we would provide CT simulation fluorofusion. So on the left-hand image, you can see what the image would be conventionally for the interventional cardiologist with no fusion. On the middle image, you can see landmark fusion, where we're providing anatomical land points. and on the right-hand image, a full volume rendered fused image where the interventional cardiologist knows the boundary points at where to deploy the valve. And this provides as a roadmap for the interventional cardiologist to obtain good procedural outcomes. So we do have a number of other technologies that we are evaluating currently for the use in the transcatheter domain. This is an example of holography. So this is a 3D screen. My hand is on the right-hand side and I'm manipulating the CT dataset to look at the anatomical detail in further detail, doing away with conventional mouses and keyboards. So this is an example of a virtual CT hologram that we presented in collaboration with Siemens Healthcare a couple of years back. We also have access to true holography. So this is a true hologram that was presented in the cardiac cath lab to the interventional cardiologist, whose finger you can see on the image. And he's able to manipulate the CT data set live in the cardiac catheter laboratory to be able to look at the anatomy of the data set before he's actually going to proceed to perform his case. So this is a hologram that is projected into the air using a specific platform. So we have all of the anatomical detail available. And clearly there is the role of 3D printing. And currently we use 3D printing where we feel there's going to be high definition information that's going to be of relevant, or in particular for complicated cases for our interventional cardiologists or indeed surgeons. So I'm going to stop there. That really was a whistle-stop tour of what we're currently doing in terms of state-of-the-art transcatheter mitral valve planning. And I'd be very happy to take any questions that there may be from the audience or the faculty members.
Fabulous presentation, really showcasing how the imaging actually will become integral part of the interventions in mitral valve disease, and actually how interventionalists will be actually benefiting from the close collaboration with the imaging specialists. Congratulations, thank you for that. So I would like to open the discussion, questions from the panel. Maybe one quick comment. So you mainly focused on the valve replacement. Do you see, or do you also work on the imaging guidance with the CT in the repair therapies? I mean, the mitral clip or annuloplasties. Do you see the potential there?
Yeah, I think that's a very good question. So I think the way I would think about transcatheter mitral valve repair or replacement is that if you're looking at edge-to-edge repair, transesophageal echocardiographic imaging and transthoracic imaging is the mainstay. So we would not use CT for edge-to-edge repair, either with the Edwards-Pascal device or the Abbott MitraClip device. When you're looking at direct or indirect transcatheter mitral valve annuloplasty repair, then you need both. You need CT and also echo. For transcatheter mitral valve replacement, we use echo as our screening criteria, and for the peri-procedural guidance, that everything is based on the CT planning in terms of suitability.
Do you think that the neo-LVOT area is the whole story, because we have like 90% rejection rate for the TMVR because of the risk of neo-LVOT obstruction? Are there any factors?
Yeah, I think that's a fantastic question. And I think much has been made of the neo-left ventricular outflow tract area over the last few years. I don't think it is the complete story. I think we should be moving beyond areas in a binary number as a cutoff point, like for 1.7 or 1.8 centimeters squared, to incorporating full-blown computational fluid dynamics and predicting physiology. Gradient and obstruction is a physiological phenomenon that's measured in pressure. So I don't think anatomy can necessarily equate to physiology. So I think that these cutoff points and boundaries are set because these bars are set very, very high, and that's what's accounting for high screening failure rates. I think once we use patient-specific anatomy, patient-specific modeling, then I think we'll have a higher acceptance rate. But this is going to be the main limiting factor for device implantation at the moment.
Professor Rajani, thank you for the wonderful presentation. I would like just to ask one question to my fellow surgeons, colleagues. So do you find this CT scan modeling useful in planning your mitral valve repair, maybe in the sense of, let's say, predicting some SAM complication or something like that? Can it be useful? Can we do it, or should we do it, or shouldn't we do it at all?
I don't know what exactly to answer. Probably yes, but generally not. I mean, in some cases, but I still, I mean, it's pretty new thing to me, and I need some time to think about, you know, what will be its use in mitral valve repair. But so far I can't see in how is it going to help us in preventing the SAM, because you know the surgery techniques are the basic one, the principal one, the surgical skill, and you know obeying to rules for preventing the SAM. Maybe for surgical point of view, the principal importance, you know, what is concerning me the most is a calcified mitral valve annulus, and which is, you know, something you have to be completely aware and to be a full plan before entering surgery in cases of complex, a huge mitral valve annulus calcification. You know, this is going to, for me, that will be the most valuable use of these imaging techniques for from a surgical point of view.
May I just ask how time-consuming it is? I mean, how much time do you need to work on one patient to give some reliable answers and data? Because, you know, if we talk about using this for surgery, if for every patient you need to spend few days to work on, then it's probably not realistic, at least at this stage of the development. And whether you believe it's going to become kind of automated process that can, you know, with a one button click give you an answer to many questions.
If I just can, sorry, if I can just lean on the question from Professor Deja, from all of this measuring, which looks fabulous, is any measure that is most sensitive to perform, maybe prone to any mistake during the process? From all those computational measuring.
Okay, so I mean, I think there's a few questions, all of which are fascinating, and they're things that we've been trying to address over the years. I think coming to one of the first comments about what could be the relevance for mitral valve surgery, and I think that's a very good point. So we would not routinely perform any of this for conventional mitral valve surgery, but we do also have an academic interest in predicting what the response to the left ventricle is going to be once you remove the mitral valve regurgitation. And we all have been faced with a situation where you have a patient who's got severe mitral valve regurgitation, the left ventricular ejection fraction is 58%. Some patients' LV function is going to decline following surgery, some's going to stay the same, and some is actually going to improve. So we are looking at techniques using this fluid dynamics and wall stress to predict better which patients the recovery of the left ventricle is going to be more secure, because at the moment it can be highly unpredictable, particularly in patients with secondary mitral valve regurgitation. It really is, you could toss a coin, is the LV going to reduce in function? Is the patient going to have cardiogenic shock afterwards? Or is the patient's LV going to recover and they're going to derive a maximum symptomatic benefit? So I think modeling of left ventricular recovery responses potentially will be an area in the future which I think will be beneficial to surgeons, and clearly the mitral valve annulus calcification domain. Also minimally invasive mitral valve surgery with mini thoracotomies, when there's a risk of damage to the left circumflex artery, we can do lots of planning and simulation and modeling to look at the height of the circumflex artery from the mitral valve annulus from the CT data set. With regards to the time it takes, absolutely right. You know, some of these techniques are exceptionally time consuming. We would only perform, we have lots of different strategies. So the routine CT planning that you see about sort of putting in a static image and measuring the mitral valve annulus, that is about 4 to 5 minutes worth of work, and looking at optimal fluoroscopic projections, 4 to 5 minutes work, it doesn't take much time. That's existing software packages. For the finite element modeling, the turnaround time would be 24 to 48 hours. For the full computational fluid dynamics, it's still very much in the research domain. We use a lot of AI, it's high-grade supercomputer work. That can take up to 25 to 30 days. So it's not ready for routine clinical use at the moment, but you know, I think as machine learning, neural networks and deep learning, artificial intelligence comes into play, I think we are working on speeding up that process, and we're working very hard with Medtronic and Edwards to try and validate some of this data and also to speed it up at the same time. What was the third question? Oh, would we do this on all of our cases? No, we wouldn't do this on all of our cases. We do serve England in terms of complicated transcatheter mitrals. So for all of the MAC cases, we would do the full complement and use all of the arsenal of techniques that we have, because they are the ones that are associated with a high risk in terms of mortality and morbidity at 30 days and also 12 months. For standard cases, we would just do the basics and we would get a turnaround time of about 24 hours.
Yes, I'm very impressed by the images, and especially by the real-time fusion images. And I was wondering, the heart is moving with respiration, the heart is moving with every beat, and during transcatheter interventions, the catheter displaces structures of the heart, like the interatrial septum during the puncture. How far are we with fusion imaging so that our virtual images really follow the structures of the heart during the intervention?
Yeah, it's very good actually at the moment. So the steps are very quick. You would do your segmentation and imaging planning on a platform first of all. That would then be fused on two orthogonal views in the cardiac cath lab. The fused image would then track the fluoroscopy, both during respiration and during the procedure. So it's fairly robust actually. So it will move with the fluoroscopic images and also the heart moving.
Okay, I think we should move for the sake of time. Thank you, Professor Rajani, for a really beautiful presentation and the discussion. So I would like to call Dr. Kirćanski to tell us something about the role of the CRT in mitral regurgitation management. So, Ratso, please.
Dear colleagues, thank you for the opportunity to talk how can an electrophysiologist device implanter be of help, how can help a patient with mitral valve disease. It's my pleasure to talk about it. It's my honor to talk instead of Professor Milašinović, who is unfortunately not able to come here today. My lecture regarding the role of CRT in mitral regurgitation management is intriguingly subtitled Beyond the Guidelines. As proposed, I will continue in Serbian language. Dakle, da li je ovaj naš naslov predavanja u neku ruku zavaravajući? Da li uopšte možemo da pričamo o CRT-u kao tehnici koja rešava mitralnu regurgitaciju, popravlja mitralnu regurgitaciju kod selektivnih bolesnika, ili nasuprot baš ovome, da li CRT upravo, da li značajno koriguje mitralnu regurgitaciju, sekundarnu mitralnu regurgitaciju, i ovo predavanje upravo naglašava značajnu funkciju CRT-a. Zašto je naslov možda zavaravajući? Jer ako pogledamo tekuće preporuke za CRT, koje su u stvari preporuke iz 2013. godine za pacing i resinhronizacionu terapiju, preporuke za srčanu slabost koje se delom tiču CRT iz 2016. godine, a ako znamo da preporuke ERINE, koje in extenso treba da budu objavljene u toku ove godine, do kraja ove godine, ne donose ništa novo, neće doneti ništa novo u vezi sa funkcionalnom mitralnom regurgitacijom i CRT-om, onda baratamo samo sa ovim činjenicama. CRT je indikovan kod bolesnika sa srčanom slabošću, simptomatskom srčanom slabošću, niskom ekcijalnom frakcijom, širokog QRS-a, koji su simptomatični uprkos optimalnoj medikamentnoj terapiji. Dakle, sekundarna funkcionalna mitralna regurgitacija nije indikacija za CRT per se, niti je jedan od kriterijuma za CRT implantaciju. Sličnu poruku nose i preporuke o valvularnoj srčanoj bolesti iz 2017. godine, koje ne navode CRT kao indikaciju za za korekciju sekundarne mitralne regurgitacije per se, a svrstavaju CRT u sklop optimalne medikamentne terapije pre nego što se pređe na transkatetersku reparaciju ili hirušku intervenciju. Ove preporuke, na utisak, targetiraju uglavnom hirurgiju ili transkutanu reparaciju. Sad, poslednje preporuke u vezi sa ovim, koje su izašle preko 2 meseca, u stvari nisu preporuke, nego joint position statement, koje takođe u vezi sa CRT-em ne donose ništa. On je na vrhu ovog algoritma sa desne strane i ne menja se dakle ništa u indikacijama. Ima se utisak da ove preporuke donose nešto novo jedino u smislu multidisciplinarnog pristupa u vezi sa rešavanjem sekundarne mitralne regurgitacije, gde CRT ima svoju ulogu, a takođe se stiče utisak da su uglavnom objavljene nakon što su objavljeni rezultati velikih studija sa MITRA klipom, COAPT i MITRA HF. Tako da, možemo da pričamo o tome da je naslov misleading, ali nije. On upravo pogađa poentu CRT-a. CRT koriguje sekundarnu mitralnu regurgitaciju. Postoje 3 CRT studije, nisu landmark, ali su prve CRT studije, važne su CRT studije KRHF, Miracle i Mastic, iz kojih gde je pokazano da CRT smanjuje sekundarnu mitralnu regurgitaciju i to smanjuje značajno. Interesantno, jedino ove 3 CRT studije su se bavile korekcijom mitralne regurgitacije pomoću CRT-a u osnovnoj njenoj analizi, ostalo su subanalize. S obzirom na auditorijum nisam u startu pričao o kakvu mitralnu regurgitaciju CRT targetira. Naravno, radi se o sekundarnoj funkcionalnoj mitralnoj regurgitaciji koja ima oko 20 do 50% bolesnika sa HFRF, bez obzira da li iz hemijske ili ne iz hemijske etiologije i koja je rezultat RVR modelovanja, disinhronije, neadekvatnih sila zatezanja i zatvaranja valvule, a u slučaju persistentne long-standing atrialne fibrilacije ili u slučaju permanentne atrialne fibrilacije, mehanizam nastanka sekundarne mitralne regurgitacije može da bude i drugi, radi se o dilataciji mitralnog anulusa, na primer. Sad, kako CRT u svemu ovome radi? Kod tipičnog CRT kandidata, u stvari kod dobrog CRT kandidata, disinhronija je posljedica bloka leve grane. U bloku leve grane postoji depolarizacija leve komore oblika slova U, U-shaped, koja podrazumeva da se signal širi preko desne grane Hissovog snopa, odatle transseptalno na septum leve komore, a potom na posterolateralni zid leve komore. To direktno znači da kasni kontrakcija posteromedijalnog papilarnog mišića, poremećene su sile i tajming zatezanja valvularnog aparata, listića mitralne valvule i to direktno dovodi do sekundarne, to jest funkcionalne mitralne regurgitacije. Kako CRT tu pomaže? Ako elektrodu CRT plasiramo u posterolateralnu i lateralnu granu koronarnog sinusa i pejsujemo sa posterolateralnog i lateralnog zida leve komore, front aktivacije se u idealnom slučaju spaja sa intrizičkom aktivacijom preko desne grane Hissovog snopa i električna disinhronija je manje ili više korigovana, postoji sinhronizovana konstrakcija papilarnih mišića i postoji ono prethodno što je bilo narušeno, korekcija sila zatezanja mitralnih listića i tajming tog zatezanja. Svodi se na to da je više ili manje sekundarna mitralna regurgitacija korigovana. U praksi dobro poznat efekat CRT-a izgleda ovako i kad bismo sumirali efekat CRT-a na funkcionalnu mitralnu regurgitaciju, ovo su mehanizmi. Globalnom resinhronizacijom povećavaju se sile zatvaranja mitralne valvule. Lokalnom resinhronizacijom smanjuju se sile zatezanja i dovodi se do postoji popravljanje geometrije zaliska i funkcije. Sad, ovde globalna resinhronizacija podrazumeva promene benefite CRT-a na nivou cijele leve komore, a lokalna resinhronizacija podrazumeva efekte CRT-a lokalno na nivou mitralnog aparata. Postoji još jedan interesantan efekat CRT-a, mogući efekat CRT-a, tiče se AV sinhronizacije. AV vremena mogu se programirati koliko se radi sinusnom ritmu CRT-om, a to može da dovede do korekcije dijastoje mitralne regurgitacije. Dobro, ovo su teoretska razmatranja. Kako je to prevedeno u kliničku praksu, kliničke dokaze? Da li CRT stvarno koriguje sekundarnu mitralnu regurgitaciju? Sad, da ne bude da smo nismo počeli od first things first, ovde svakako first thing, kad se gleda klinički dokazi, preživljavanje za sve studije, za sve tehnike. Evo jedne velike studije, relativno velike, 10-70 bolesnika sa dugim, izrazito dugim, nestandardno dugim follow-upom za CRT studije, koja je pokazala bolje preživljavanje ako je CRT smanjio sekundarnu mitralnu regurgitaciju u odnosu na situaciju gde to se nije desilo ili gde CRT nije bio implantiran. Ova studija nije jedina koja pokazuje povećano preživljavanje u slučaju da CRT smanji sekundarnu mitralnu regurgitaciju, ali to je set tih studija koje se tiču koje kvalitativno određuju efekat CT, u smislu povećano ili nije povećano preživljavanje. Ovaj rad je bitan da se istakne, jer jedini se bavi kvantitativnom analizom kako stepen funkcionalne regurgitacije, koji stepen funkcionalne regurgitacije i njegova promjena pod CRT-om utiče na preživljavanje. Treba primetiti da se isto radi o velikoj studiji, relativno dugom follow-upu, koja je pokazala smanjeno preživljavanje kod umereno teške i teške sekundarne mitralne regurgitacije koja nije promenjena nakon 6 meseci primjene resinhronizacione terapije. To je na Kaplan-Meyerovoj krivoj poslednja linija. Sad, ovde je još interesantnije što je ovaj efekat bio nezavisan od odgovora na CRT i bio je nezavisan od volumetrijskog odgovora na CRT pojedinačno. Drugi klinički bitan element hospitalizacije. Doduše, nema studije koje se bavi samo hospitalizacijama. Ovde je kao composite endpoint uzeta hospitalizacija i smrtni ishod i nedvosmisleno pokazano da ako postoji responder u smislu MR improvementa na CRT, to je povezano i sa manjim brojem hospitalizacija. Dug follow-up opravdava da ova studija bude interpretabilna i da se uzme za relevantnu i činjenica da su 3 od 4 bolesnika imala smanjenje sekundarne mitralne regurgitacije kod bolesnika tretiranih u studiji. Benefit od smanjenja sekundarne mitralne regurgitacije je pokazano da je nezavisan od CRT-a, to je bitan podatak i ovo direktno implicira da je korekcija sekundarne mitralne regurgitacije ima kliničke benefite koje su očigledno iznad CRT responsa. Slično u KRF studiji nije ovo jedina studija koja pokazuje, niti postoji samo jedna, u više studija su svi ovi klinički efekti dokazani. Međutim, ovde je stvar debate, a vidjet ćemo posle u delu gaps in evidence, na primjer, da sve ovo može da bude samo pitanje kako se CRT responder definiše. Sledeći bitan klinički pokazatelj, aritmijsko događanje. Aritmijski tok bolesnika nakon implantacije CRT, u zavisnosti od toga da li je došlo ili ne do korekcije sekundarne mitralne regurgitacije. U ovoj studiji isto novijeg datuma bilo je manje ventrikularnih tahikardija, ventrikularnih defibrilacija registrovanih preko CRTD defibrilatora kada je CRT popravio sekundarnu mitralnu regurgitaciju. Što se tiče diskusije, zašto je to tako, mislim da se diskusija svodi na potpuno iste argumente kao što se sakubitril valsartan sad pominje kao lek koji svakako nije antiaritmik, ali koji može smanjiti aritmijske događaje kod bolesnika kod kojih je primenjivan, a svodi se na reverzno remodelovanje leve komore. Sve ove studije koje smo menili i eho analize odnose se na eho poboljšanja mitralne regurgitacije u miru. Šta je sa ehokardiografskim pokazateljima tokom vežbe, to jest u fizičkoj aktivnosti? Time se bavila intenzivno ova studija, doduše starijeg datuma, što je ispostavio se bitno interpretacije rezultata, koja je pokazala da CRT smanjuje u miru i rano, to znači odmah posle, i kasno, to u ovoj studiji kasno znači 3 meseca, posle CRT-a, dakle, smanjuje sekundarnu mitralnu regurgitaciju. CRT smanjuje sekundarnu mitralnu regurgitaciju tokom vežbe samo kasno nakon CRT-a. Ono gde CRT ne radi je jedna od ovih 6 zaokruženih slika, a to je CRT ne smanjuje sekundarnu mitralnu regurgitaciju tokom vežbe odmah nakon CRT-a. To je kratko diskutovano da je potrebno vreme za reverzno remodelovanje, ali ja bih diskutovao na još jedan način. Konkretno, CRT ne smanjuje sekundarnu mitralnu regurgitaciju prema ovoj studiji rano nakon implantacije, zato što je potrebno vreme da se električna resinhronizacija prevede u, kako kažemo, organsku, da se dilatacija anulusa smanji, da se smanji sferičnost leve komore, da se tenting area mitralne valvule smanji i tako dalje. Međutim, bolja AV optimizacija može da dovede, siguran sam, i do ranih odgovora u ovom smislu i u studiji nije analizirano kako izgleda QRS. Studija je iz 2007. godine, a preporuke sa CRT su se značajno izmenile i sada s CRT-om targetiramo ljude koji na osnovu oblika QRS-a mogu da odgovore u stvari na CRT, što u ovoj studiji ne možemo napraviti analizu jer ne znamo kako je tačno oblik QRS-a izgledao, davno je to bilo. Prediktori popravljanja sekundarne mitralne regurgitacije posle CRT-a su pre svega ehokardiografski. Ja ne bih zalazio u ehokardiografske te teme, s obzirom da nisam ehokardiografista, a izdvajam ono što se eventualno tiče elektrofiziologa i ovde je u ovom slučaju malo apsurdno. Ova studija je pokazala, već smo je pominjali, da je širina QRS-a jedini, nakon multivariantne analize, jedini pokazatelj pozitivnog odgovora na CRT, pozitivnog u smislu smanjenja sekundarne mitralne regurgitacije. I sad proizilazi da je to bitnije od QRS morfologije. To ne stoji definitivno nigde, obično ne stoji, ne važi za pozitivan odgovor na CRT, tako da ove rezultate bih diskutovao u pravcu toga da nije navedeno, ako se ne radi o bloku leve grane, kakav je oblik QRS-a kod bolesnika koji su uključeni u ovoj studiji, to jest kod onih bolesnika koji nisu imali blok leve grane, a implantiran je CRT, da li se radilo o specifičnom bloku desne grane, o bloku desne grane sa levogramom, o interventricular conduction delayu, što sve ima različite odgovore na CRT, a samim tim najverovatnije ima različite odgovore u smislu popravljanja sekundarne mitralne regurgitacije. Dobro, pomenuo sam eho, prognostičke faktore za popravljanje sekundarne mitralne regurgitacije, to su eho pokazatelji u smislu mehaničke disinhronije tenting area do onih najjednostavnijih LV endijastalnog dijametra. Nećemo dalje ovo analizirati. Ono što je poslednje, što je nekako uvod za sledeće predavanje, je šta ako imamo CRT nerespondera koji nema popravljanje sekundarne mitralne regurgitacije ili čak zaostala sekundarna mitralna regurgitacija, nepopravljena sekundarna mitralna regurgitacija dovodi do tog responsa. Takav pristup, takvi bolesnici, takav profil bolesnika je analiziran u Permit Care studiji sa MITRAL klipom, koja je bila pozitivna studija i kod ovog profila bolesnika, nakon ugradnje MITRAL klipa, smanjila je NIHA klasu i smanjila je stepen sekundarne mitralne regurgitacije, povećana je frakciju leve komore, ali samo 51 bolesnik je u pitanju, trajanje 1 godinu, trajanje praćenja, u pitanju je obzervacijona studija, i jedan podatak koji je isto, ima vjerojatno implikacije za neke buduće guidelines-e i tajming za odlučivanje kad ugraditi MITRAL klip, je da je kod ovih bolesnika prošlo 3 godine od CRT-a, znači oni su bili 3 godine non-responderi, a nakon toga je MITRAL klip ugrađen. Priču o MITRAL klipu i CRT-u nastavljaju COAPT studija i MITRA FR, ali to je tema sledećeg predavanja, pretpostavljam. Mnogo ima nepoznanica u smislu sekundarne mitralne regurgitacije i njene veze sa CRT-om. Trekući pristup, važeći pristup u vezi sa sekundarnom mitralnom regurgitacijom i CRT-om je zasnovan na observacionim studijima, nema randomizovanih kliničkih studija. Pacijenti koji su čak uključeni u landmark CRT studije, u tim studijama nisu specifično te studije nisu specifično targetirane da analiziraju sekundarnu mitralnu regurgitaciju posle ovog tretmana. U pitanju su rezultati koje dobijamo, rezultati su naknadnih analiza, subanaliza. Takođe, postoje značajne teškoće u interpretaciji, generalizaciji pre svega rezultata. CRT indikacije su se značajno promenile, recimo u poslednjih 15 godina. Postoje značajne teškoće u interpretaciji rezultata, jer postoje različite strategije programiranja koje su se takođe vremenom menjale, a CRT algoritmi su se takođe promenili na bolje. opet ovo se sad tiče više ehokardiografije, postoje i različite definicije sekundarne mitralne regurgitacije, na primjer definicije evropskih i američkih udruženja. Dakle, uprkos značajnom nedostatku u dokazima u vidu randomizovanih kliničkih studija, znamo da CRT može da poboljša, ali i da ne promeni, čak pogorša sekundarnu mitralnu regurgitaciju. Međutim, dobar CRT kandidat koji ima blok leve grane, pravi blok leve grane koji je širok preko 150 milisekundi, bolesnik koji nema ožiljak u posterolateralnom, to jest lateralnom zidu leve komore, što je target zona za LV elektrodu, će najverovatnije imati benefit od CRT-a u smislu poboljšanja sekundarne mitralne regurgitacije. I s tim u vezi, u većini slučajeva CRT responder će poboljšati i obrnuto, poboljšana sekundarna mitralna regurgitacija će označiti dobrog CRT respondera. Poboljšanje sekundarne mitralne regurgitacije je nezavisan prediktor dobrog odgovora na CRT i nezavisan prediktor poboljšanog preživljavanja. Ono što se forsira u guidelinesima je da evaluacija pacijenta sa CRT-om treba da bude urađena i pre i posle ugradnje, ali evaluacija ne samo u smislu RV remodelinga, već i u smislu promene sekundarne mitralne regurgitacije. Trenutno aktivan pristup za tretiranje ovih bolesnika je graduisani pristup koji podrazumeva prvo implantirati CRT, a onda čekati određeno vreme i procenjivati da li treba još nešto da se radi, to je naknadno procenjivati stepen sekundarne mitralne regurgitacije ukoliko je ona postojala ili nije postojala na početku. I odluke treba da donosi multidisciplinarni tim koji uključuje specijalistu za srčanu slabost, kardiovaskularni imaging koji uključuje interventnog kardiologa koji ima iskustvo sa MITRAL klipom, tim treba da uključi elektrofiziologa i naravno kardiohirurga. Hvala na pažnji.
Thank you, Dr. Kirćanski, for your beautiful presentation. Now the paper is open for the discussion.
It's a very important lecture, and any surgical meeting has to include a session about CRT. You know, because this is a desperate situation for everybody when you have a functional MR and when you don't know what to do, because yes, we can operate it, and yes, that could get good results, but in high-risk patient, it is a difficult decision, you know, to try to make a try and error experiment. So we don't have it in our institution some kind of, you know, precise measuring or follow up on those patients. So our experience is generally on, you know, individual level. But we really found, you know, important influence of CRT on our patients' outcome. And what is important, I mean, as a surgeon, CRT in responders could be, you know, life destiny therapy if the patients are high risk, or could be a bridge to decision. You know, if we have a functional MR and a huge left ventricle, and if we have a CRT patient, a CRT responder, and we obtain, you know, after a couple of months or during a time some reverse remodeling, the future of the repair and the probability of the repair, the stability of the repair will be much better, you know, although we have never do it so far. But, you know, according to our experience, it's a quite a logic, you know, further step maybe to think in responders. It is difficult, you know, if you have a patient, I had last year, I think that Professor Milašinović put a CRT on him, and was a patient of me and Professor Vukčević, who had a very bad anatomy, LV of 30% and huge dilated left ventricle. So he got CRT, he responded, and after all we did only cabbage surgery on him without mitral valve repair. I didn't want to jump into the mitral valve repair on him because of his huge body and very bad anatomy, and knowing that it will be a very long and demanding procedure, I'll let it like this. But you know, imagine that you have the same situation in patient which is suitable for a mitral valve repair, and you can do faster repair in him. That could be a very nice, step in arriving at the point to repair the valve. Thank you very much for your presentation.
Thank you for the comment.
I have two short questions. One, first is, do you think that the his bundle pacing can improve this outcome in terms of mitral regurgitation? And second question is that if on top of this you do the pulmonary vein isolation in case of atrial fibrillation, does it impact the MR?
Okay, I intendedly didn't mention his bundle pacing because the experience, there are no lot of randomized controlled trials regarding conduction system pacing and his bundle pacing, which was the first technique applied. The other one is LBB pacing, because there is no even randomized controlled trials regarding the successful of his bundle pacing and late prognosis, etc., etc. But I am a fan of his bundle pacing, conduction system pacing, and I think in patients where his bundle pacing and conduction system pacing can correct QRS duration, interventricular conduction delay, bundle branch block, we can expect to have responder also regarding secondary mitral valve regurgitation. So we don't have clinical data regarding that, and we are waiting them.
Okay. Any more questions? If not,
actually, I do have a comment.
Professor Perić.
Regarding all the devices that you are implanting, regardless of what kind of device is. Yesterday on this Medscape appeared a serious article warning that it is definitely proven that iPhone 12 interferes with the work of all your devices. So before you jump into the conclusion regarding responders, non-responders, warn your patients not to use iPhone 12 at least.
Okay,
I assume that not many of them have it, but
yes,
if one of the iPhones or any mobile phones interfere with the work, it's pretty much sure that others also do so. So we have to face new realities, you know, and whatever we suspected, but nobody's, at least to the moment, is not brave enough to say openly. But yesterday, it was published. You know, so we have to be careful about it.
I heard about that, and cybersecurity issues with cardiac implantable electronic devices are always present, but manufacturers always solve that problem. Hopefully, they will do it this time also.
Okay, Dr. Kirćanski, thank you very much.
Thank you.
So we'll move on now, and it's my special pleasure to introduce our next speaker, our great friend and great expert in treating heart failure and mitral valve disease, Professor Josef Bartunek. Please.
Thank you very much. Good morning, and I would like to first thank to Marko and Sveto for having me here, for organizing this meeting. It's wonderful that, as was several times mentioned, that this is actually the first meeting that is done impartial, still in the physical presence of at least faculty, and it feels different. It feels very energizing, and I think this is the new milestone, how we are getting back to the new normal. So it's my pleasure to present you my opinion or about the percutaneous treatment of mitral valve disease. It's a very broad topic, and I'd like to walk you through some issues about the patients, devices, evidence, and challenges. It's always good to think or to see the real patients or cases behind what we are talking about. I will not talk about the chiropractic classification. I will just show these two examples of two main phenotypes of mitral insufficiency. One on the left is a functional mitral insufficiency with severe MR, severe remodeling. On the right is a classical prolapse, failed leaflet on the P2. So what we can say about these patients? Well, we know that as such, the population of patients with mitral regurgitation is undiagnosed, as we see from this data published 5 years ago. We also know the prevalence of mitral insufficiency is growing over time and with the age. We also know that mitral insufficiency leads to the poor prognosis, and that regardless of ejection fraction, both in groups patients with normal and reduced ejection fraction, patients with moderate to severe isolated MR have excess of mortality. Now, when thinking about the treatment options, it's good to have a look on this slide. You know, it's a basically mitral valve, it's a chorda, it's basically what we are dealing with, what kind of targets are we going to have. And actually there are several targets, starting from the valve, the leaflets, annulus, chorda, entire valve. And in case of secondary mitral insufficiency, we should also not forget the left ventricle. So being didactical, obviously we can divide the options into 3 categories, in fact, including the transcatheter valve remodeling, not topic of today, but there are 2 main categories addressing the mitral valve regurgitation. In case of mitral valve abnormalities, it's a mitral valve repair and transcatheter mitral valve replacement. So I'd like to walk you through the basic information about the available devices for each of these percutaneous options. When speaking about annuloplasty, we have 2 approaches. One is indirect. This is a first device called Carillon, where basically we are putting device into the coronary sinus. This is could be very easy procedure, but there are several concerns about the potential impact of the reduction of the mitral annulus given the distance between the coronary sinus and the annulus itself. It can be varying. They're also concerned about potential safety because it could be in trajectory of the LSAX, and there is a limitation that this procedure cannot be used in a patient with a previous CRT. Nevertheless, there are data from one randomized control trial demonstrating in the selected patients the beneficial outcomes as regards the reduction of mitral insufficiency and also the clinical survivals. Other device, now still actually obtained only the CE mark, it's called Arto device. It's basically a similar approach, but using the adjustable bridge suture between great coronary veins and arterial septum, basically allowing adjustable the reduction of the mitral ring and improving the coaptation. So indirect, direct, they are basically trying to mimic the surgical procedure. The most known to us is a cardio band, which has been introduced actually almost 7 years ago. I remember still Hugo Wannerman when he was promoting this approach as a tool to get to our center. It's a very thoughtful approach, very predictable, very structured. It could be also demanding, but it's feasible, and thanks to adjusting the cinching of the annulus, that could be very significant improvement in the mitral insufficiency. CE mark has been obtained, and the randomized control trial ongoing. Another most recent is a millipede system from Boston Scientific, which is interesting in its design, and there are several features that are also of interest. So this is like a zigzag stand with 8 anchors who are basically positioned on the annulus, and they allowed individual cinching between different anchors, reducing the annulus size, improving coaptation, basically tailoring to the site location of the mitral insufficiency. What is interesting is it allows, using the technology of Boston Scientific, it allows direct visualization. So basically you are seeing what you are doing. There's a feasibility study that was published, and I think, as far as I understand, there is a new study in planning to address the clinical relevance of this new approach. This is for annuloplasty, and then we are moving something more established, where we have more experience, and we are talking about the leaflet therapy, transcatheter edge-to-edge repair. We all know MitraClip started in 2003. now having the Gen 4 generation with some adjustment as regards also monitoring, also allowing control grip actuation. Basically, very established technology and more than 90,000 cases and with 2 randomized controlled pivotal trials. Another device that is also addressing the same concept of edge-to-edge repair is a Pascal device from Edwards Life Sciences. Device has 3 components. Basically, there are pedals that are broader than the clips arms in the MITRAL clip, allowing the stress, distribution on the native leaflets. There are clasps. They are actually allowing very fruitful individual grasping the grasping of the leaflets during the procedure. And there's also a spacer that can fill the regurgitated orifice, thereby allowing the use of this device also with the huge mulch coaptation settings. The study that was addressing the relevance of the system in the clinical practice is called CLASP, about 124 patients. Recent data were presented at the EuroPCR, presenting a 2-year follow-up. In the next slide, I would like to dive more deeper into the very hot topic, still hot topic of use and adoption of the MITRAL clip in the clinical practice. So basically, it comes always to the fact, first of all, that how easy, how basically adoptable is this technology when you think about that this simple device with maybe robust, difficult manipulations is diving into the complex anatomy. I think we have to definitely acknowledge the fact that the MITRAL clip procedure is very structured. It's image-guided, predictable, and safe. I think that's a very important first step when we are talking about percutaneous interventions. There's huge experience, as I said, with the high success rates. So technically, I think this is teachable, this is adoptable in almost, I would say, in the routine clinical practice, in the routine cath labs. Now, what are the data? How we can take this predictable, safe, nice image-guided procedure into the practice, how we can adopt it in benefiting our patients. So far we are basically relying mainly on these 2 randomized controlled trials, MITRA-FR and COAPT, who were comparing MITRAL clip and guideline-directed medical therapy against GDMT alone. And this is maybe still worth to repeat, to basically point at the certain differences between both studies. They are listed here. The very first one is basically design of the study. The design between MITRA-FR and COAPT is given, or depends on the quantification of mitral insufficiency, also on the exclusion of the patients with the marked LV dilation in the COAPT trial, also assuring preservance of right ventricular function and moderate pulmonary hypertension in the COAPT trial. Thereby is no surprise that the degree of severity of mitral insufficiency has been greater in the COAPT study, and the degree of left ventricular dilation has been smaller in the COAPT study. Second difference is the practice, how the patients were basically entering to the study. MITRA-FR is reflecting the real world. You have a patient, you see the significant MR, he's on the meds, but you take a decision, hoping that will allow you maybe, the intervention allows you maybe to titrate medication further. Thereby you sort of shoot into your own leg because you have a sort of real life world that you cannot maybe ascertain what actually is helping these patients. In the COAPT study, there was very strict selection by central selection committee, ensuring upfront optimal therapy and avoiding any major changes in the medical therapy over the time. Final difference is a little bit about the technique and procedure. There is also discussion, but what basically comes to that the success in the reducing of mitral insufficiency to the grade 2 and lower was higher in COAPT as compared to MITRA-FR. It was either at procedure or the 1-week follow-up. Having this in mind, actually, you sort of can expect that probably the MITRA-FR would not be that strongly positive, and indeed there was no difference between the active treatment versus the standard of care as regards the impact on the combined endpoint of all-cause death and first unplanned hospitalization for heart failure. In co-opting was actually very positive and positive across all the primary and pre-specified secondary endpoints. Here we are just showing the impact on the all cumulative heart failure admissions on the left and all-cause mortality. We also know that from the co-opt that the benefit of the mitral clip in this particular patient population actually stable. It's preserved also up to 3 years. So basically, based on these two trials, one of the take-homes for the adopting in our practice will be this proposed for the mitral clip care pathway, that we would take the patients who are symptomatic, despite optimal medical therapy, they should have significant MR, and I think that could be discussion about how to quantify that. I think probably the most relevant would be the RF, more than 50%, which is very consistent among the guidelines. And you have to ensure that the patients have optimal criteria as regards anatomical eligibility to implant the clip. There should be a right degree of left ventricular dysfunction. And again, we rely now very much blindly on the criteria of the co-opt, saying that the ancestor diameter should be less than 70 millimeters, and EF should be at least 20 and above %. There should be no significant RV dysfunction or severe pulmonary hypertension. And having this, we should basically refer the patients timely for the interventions where we can achieve the benefit on the clinical outcome. This is basically how the recommendations here. The question will be now, how we are basically working in the real life. Are we following that? Is it really adoptable? Is it the information that is collected in the very strict, controlled design setting? Is it something that we are going to basically comply with? We are going to basically doing in our practice. And just as a teaser, I would like to show you two sets of information. It's a teaser. There is no true clinical science behind it. It's a teaser of how actually we are working. One is basically this experience from our own center. In Belgium, we are forced to work in the network. Basically, you ally with 3 or 4 centers, and you do procedure in one center, and you get a referral from different places. So we are basically working 4 centers with 90 cardiologists. Very different opinion about who should be clipped, who should not. And I would like to show you basically our data, how basically what patient we are treating. So here you see the differences between MITRAL, FR, and co-opt. And again, I mentioned the most relevant differences. On the lower part, you see also the risk scores. One is Euro score, other is STS. You see the NT-proBNP. Actually, co-opt has a higher NT-proBNP than the MITRAL, FR, despite differences in the degree of remodeling in the MITRAL, FR, which was much more pronounced, and despite also higher degree of right ventricular systolic pressures. But look, in the clinical practice, in our basic experience, we are having, following population. We are having much older patients, close to 80. EF is 35%. You can see that with a very wide range. Actually, I can tell you that almost 20% of our patients have EF 20 and lower. Dimensions are same. What we see, we have a much more pronounced pulmonary hypertension, very close to MITRAL, FR. We also some degree of right ventricular dysfunction. We are taking also those patients. Our patient population has a more ischemic etiology, more advanced renal dysfunction, very high NT-proBNP, and very much high Euro score. As we got the therapy, actually we are very strong and we are very pushy as regards the use of the mineralocorticoid antagonists. You see very high prevalence, over 80% are on the aldosterone. And we have actually lower number of ACE inhibitors. We believe more the combination of the aldosterone and a beta blocker being more relevant as regards the outcome on the longer term. So this is basically how our patients are doing. Small numbers. This is not meant anything comparison. Simply to say that even in this patient population, without having true comparison randomization, actually you can achieve reasonable outcomes as regards the combined composite of the mortality and readmissions, reaching around 30% events at 2 years of follow-up. That's one set of data. The second is coming here. is basically, can the MITRAL clip could be used beyond the classical criteria of the co-opt and MITRA-FR. And this is the nice registry from European centers, basically reporting the use of the MITRAL clip in the patients who are on the transplant list. Either transplant list, either bridge to decision or bridge to transplant candidacy. And it's interesting to see indeed that, okay, the success rate of the procedure to be lower, around 88%. There is no mortality. You don't pay any price to the intervention. And when you see on the follow-up, just on the numbers, you see that from these patients, 30% died at the median follow-up of 600 days, so almost 2 years. There are only 6% of patients have an urgent TX transplant, and 80% has LVAD at a median follow-up of almost 483 years. When you look on the Kaplan-Meier curves of the composite of all-cause death, urgent transplant, LVAD, or first heart failure admissions, you see that up to 1 year, in fact, 2/3 of patients are free of these events, which is quite good, when you think about it, quite good for this very advanced patient population. When you look on the first heart failure admissions, you see differences, slight differences between the decision or the placement of this patient on the list, either transplant, bridge to decision, or bridge to transplant candidacy. Again, the better survival curve, no significant difference for those who are still on the bridge to decision or bridge to transplant candidacy. What also may be relevant to notice is the fact that, and it was also in other studies in the co-opt or in the MITRA-FR, the most of the events, if they happen the first 6 months. After 6 months, they get sort of stabilized. So basically saying that there are no randomized data. It's very hard to get them, but we should not dismiss these options, even to those patients who don't really truly qualify always for the co-op criteria from the clinical perspective. So after this, I would say a little bit philosophical discussion about how to use the data, how they're going to impact and be adopted in the practice. Obvious question is, where we are heading. We are on the Route 66, beautiful driveway. So where we are heading? So basically, one question is, obvious guidelines update. We have update in the American guidelines, and as we know, we discussed also Bernard, Iung. There is definitely an expectation that there will be some change, or we can expect some change in the guidelines of the valvular heart disease from ESC. Meanwhile, I think that was also pointed by previous speaker, that we have this actually very thoughtful consensus on the treatment of the secondary mitral insufficiency in heart failure. Basically, it nicely summarizes everything what we should be paying attention to. Paying attention to the expectancy of life, pay attention to the presence of the ischemic heart disease, paying attention to the dysynchrony, staging of the heart failure, and then basically taking the thoughtful multidisciplinary decision about whether or not the given patient should be or could be a candidate for the leaflet therapy. That's one direction that we are heading. The second direction where we are heading is the refining the precision, how we are going to adopt the therapy, and precision and improving the device technology. As we have the first point, I would like to focus mainly on the discussion that we had, especially in the beginning when we started the therapy. And I recall a number of discussions with our surgical colleagues actually pointing that, you never achieve the same result as when we are doing the surgery. So basically the question is, how much of residual MR in the functional setting can be tolerated? What level of MR reduction is needed to improve the outcome of the patient? And there are basically two sets of data I would like to highlight here. One is this study, the analysis from the co-opt. Again, very clean data set, clean patient population. And it's like the data set presenting the outcomes of the patient with randomized and stratified by 30-day residual mitral insufficiency, either after clip or after randomization to the guideline-directed medical therapy. What you see clearly here is that the outcome basically is similar between the patient having either mild or moderate grade 2 MR at the 30 days post the therapy or post the randomization. Only in those patients in whom the residual MR was 3 and more was the survival compromised despite of the intervention. Second information is coming from this registry, just published a few weeks ago. It's a European registry from the patients with secondary mitral insufficiency, a large number of patients, 800. And interestingly, the investigators address the question, what is the impact of residual MR grade 1 versus grade 2 on survival, depending on the left ventricular remodeling and right ventricular dysfunction. You see the cutoff values, LV dilation of 150 milliliter volume of LV diastolic volume was as a cutoff for dilation. And for the assessment of right ventricular dysfunction, they use the combined index of the ratio between TAPS and systolic AP pressure with a cutoff of 0.20, 274. When you dive into the paper, you also see some of the nice things, interesting things. You see, for instance, very low use of the mineralocorticoid antagonists in this registry, only 30 to 50% across these 4 categories. Beta blockers quite good, between 70 to 80%. So let's keep it in mind that also when we are looking at the data. So now this is the main plot of the hazard ratios. So you see these 4 categories combining the dilation and RV dysfunction. And it's clear to see that the improved outcome, survival, was achieved only patient having the not too dilated left ventricle and having preserved RV dysfunction. In all the categories, there was no major impact on the survival benefit. Now this translates to this Kaplan-Meier curve. Again, you see that those with less dilated ventricle and preserved right ventricular function, patients who had a residual MR grade 2 and more were doing worse as compared to those with residual MR grade 1. If you had any other combination of the background phenotype and of the patient, there was no benefit, no difference in the survival benefit regardless of the degree of residual MR. Nevertheless, there was always a benefit as regards the outcome assessed from on the clinical performance and the symptomatology. So there was one thing about the precision, basically saying how aggressive we should be achieving the optimal result in what subset of patients. Second evolution that we are definitely going to witness will be the improving, fine-tuning the procedural aspect, technology. The Edwards Pascal system already has from the beginning the individual grasping. The Gen 4 of the mitral clip of the Abbott is also having the same feature. It's also broader, so we can expect that having the finer, more versatile armamentarium of the devices could also improve the impact on the effectiveness of the mitral valve regurgitation reduction with the mitral clip. So let's go back to the patients. So this was the story of the devices, evidence. Let's just see actually what we have done in these patients, basically to document that how we could go around in practice with these 2 types of mitral insufficiency. So we have this patient, and you see his images. You see that the criteria of the co-opt, and on the right side we are going to see now actually what was his clinical features. And you actually see he was well treated. He was having significant MR. He was quite dilated, but not too dilated. His LV function was actually 18%. And he was still having the preserved right ventricular function without major pulmonary hypertension. So we, of course, at that time we didn't have any co-op, but we didn't actually know about the data. The patient underwent intervention, got 2 clips with a very effective reduction of the mitral insufficiency. And at 2-year follow-up, this patient was doing actually wonderfully. He remodeled, he was better, his function recovered. Now let's have a look at the organic. It was another patient with this, that I mentioned in the beginning. It's a patient with a flayed leaflet, gap of 6 millimeters. And actually, we were quite successful. With 2 clips, we could basically reduce mitral insufficiency. So we were very happy. What I want to say is following that in these patients, we can be also much less happy in the organic. This is another case, 88 years female with A2 flayed leaflet, treated with 2 clips, still important residual leak in the commissures. We could not clip it. The patient did not do very well. She came back again several times with heart fracture. She died also quite soon after the clip. So okay, what I want to say with this, that actually you should be always thoughtful when deciding whether or not and in what stage and how to basically use the leaflet therapy in the mitral valve, which is very complex. And again, re-emphasizing maybe the basic postulates of the Everest trial, we should be very careful considering the MITRAL clip if there is extensive annulus calcification, small posterior mitral leaflet, Barlow's cleft, rheumatic thickened leaflets or different thickness of the leaflets, and if there is a commercial prolapse. And with this basically you also enter the consideration, can we do it differently? Can we use the valve replacement? And this is actually a new era that started a few years ago. It's a very crowded device space, very crowded devices, but it's still in the very early stage of clinical development. As far as I understand, there are no more than 600 cases worldwide being done using the percutaneous valve. And basically this experience points at the feasibility and early procedural outcomes. Sort of to also emphasize that transcatheter mitral replacement should be seen differently than TAVR. It's not the same. There are many challenges. There are challenges, there are either valve and disease related, and it was nicely shown by Professor Rajani. It's again complex anatomy. It's a different place where we are entering, different shape of annulus. There's lots of interaction with LV remodeling and function, LVOT proximity, and no-LVOT obstruction is definitely one of the major issues. Likewise, the device-related issues, delivery system, how we are going to approach it, anchoring, annulus retention, valve sealing, valve thrombogenicity and durability is different, flow dynamics. So all the challenges basically needs to be addressed before this therapy could be, competing a valid option beyond the clinical trial setting. So in summary, basically, to bring this everything into one circle, and this is not my own slide, just modified and basically reinforcing what I would call common sense. Also, that was pointed at the ESC consensus paper. So basically, if a patient with primary MR and who has no high surgical risk, there's no discussion. These are surgical candidate. If a patient that have very high surgical risk, you can consider transcatheter treatment. When you go from the secondary MR, again, no surgical risk. You need a cabbage. Again, no brainer. It's a surgery. If a high surgical risk, yes, it's probably leaflet therapy. If there is no cabbage needed and no high surgical risk, you can still discuss, I would say. It also depends on the patient, degree of remodeling, on the experience and dynamic in the team at the local site. So when you go for transcatheter treatment, the first thing always is to say, is the repair feasible? In the ideal world, if you would have all the technology in your house, which I don't think anybody of us have, we are all limited either to one or two, you would have to assess the eligibility for all these different options that we discussed in the beginning. And if the valve repair is possible, yes, I think that's definitely the option. And if repair is not feasible, then the option would come for valve replacement. And there even, you still have to think, or we still have to think, whether or not this is the right option and the right thing to do. So with this, I would like to convey a few take-homes. First take-home is that transcatheter edge-to-edge repair with mitral clip is the first therapy shown to improve the prognosis of heart failure patients by reducing secondary mitral insufficiency. Other transcatheter-based repair or valve replacement devices are likely to mature and establish their clinical value. Further clinical development is needed to define the timing and patient phenotype benefiting from tailored mode of transcatheter mitral intervention. Surgical repair remains the first treatment choice in organic mitral regurgitation. Transcatheter repair or replacement should be considered only in case of prohibitive surgical risk in this patient population. And closing this talk with one more thing is that basically, while procedures that we are doing are rather safe and predictable, we should keep in mind that treated patients are complex. And as again, it's not enough to emphasize that we should choose indication wisely in the open multidisciplinary discussion. We should know when to say no. We should also think that the patients that are treating are fragile. We should optimize them before the procedure. We are strong believers of the hemodynamic assessment beyond the echocardiography. We do probably, we are one of few centers doing all the time right calf for every valvular heart disease assessment. I think it's needed, it's helpful, it can give you different view on the patient stage. We need to optimize heart failure medication. And then, if doing the procedure before or after, it's of course possible that they will become unstable, especially in the secondary MR. We should expect that. We should be mindful and anticipating need for hemodynamic monitoring. We put the whole threshold for the Schwann-Ganz monitoring after MITRAL clip in SMR is actually very mandatory. Discussions with the anesthesiologists, we believe that we should not overreact with vasoconstrictors, but rather use the contractile modulators. It's also making more pathophysiological sense. We should not rush discharge. This is not a competition. Our median the duration of the admission after SMR, it's 7 days. Because we are treating, so if we take time after the MITRAL clip is done to re-optimize them and send home, then they are completely correctly managed. And finally, is the team communication. It's also essential. We should be open to us, frank to us, but also honest to the patient and their expectations. So with this, I would like to thank to a number of my colleagues. I'm here on their behalf. It's my colleague with whom we are doing the interventions, including Martin. We have a wonderful heart failure unit, the cath lab team, and also we are benefiting from the very good collaboration with cardiac surgeon, Bernard Stockmann, and also the referral partners from our partners is to be appreciated. Thank you very much.
Joseph, thank you very much for the wonderful and very comprehensive talk. I would have 2 questions, and first question is for you, but also maybe for Professor Iung, and it relates to the sub-study of the MITRA FR trial, which essentially showed that patients with similar characteristics as the patients included in the COAB trial, when extrapolated, didn't benefit from the MITRA clip. So any comment on that? And just second question, who would be the best candidates for percutaneous treatment with annuloplasty? Would it be the patients with proportional TMR who are not candidates for MITRA clip, in functional MR who are not candidates for MITRA clip? Thank you.
I think for the first questions, I cannot really comment. What I wanted to show that we should not be, rigid as regards the data coming from 2 trials. The things will be evolving. I cannot comment on the differences. I think maybe Bernard can address that better about the MITRA FR and co-opt. What I want to emphasize is always really think on the patient level. Have a common sense, really having the good understanding if he's, in the right stage of potential response. And it's very elusive. We know it. It's elusive for everything that we are doing in heart failure patients. Be it cabbage, when you're going to revascularize, when does it make sense? When you do some device intervention, it's always elusive. So I think that challenge will persist, I'm afraid. The challenge will persist, and you see that the patient on the transplant list, actually, the data are not so bad, in fact, when you think about the hard endpoints. So I don't know if Bernard would like to add to that.
Just to add some words, yes, you're right that we performed this sub-study on MITRA FR by retrospectively applying co-opt selection criteria, and we did not see any benefit. Well, we have to be cautious because it's a post-hoc analysis, because we did not take into account all co-opt inclusion criteria, in particular on the right ventricle. I think it is something which is worth to be mentioned. However, I think that the way to select a patient for secondary, for transcatheter mitral valve repair for secondary MR by only applying strictly the COAPT criteria is probably not the right way to do, and I fully agree that it is necessary to have an individual approach. I think that the generalizability of the results of COAPT is somewhat hampered by the fact that these patients had a selection process which does not correspond to real life. We should not forget that approximately 30% of the patients who were screened were randomized, actually. Treatment was really optimized. I think medical therapy, I also agree, and I think that one of the factors that probably may account for some differences. So I think obviously, the best candidates are probably the patients who have the most severe degree of mitral regurgitation and who do not have too severe impairment of left ventricle and too severe LV remodeling. Afterwards, the difficulty is to determine the threshold, and it remains very difficult. Regarding your question on proportionate or disproportionate MR, this is a very appealing concept. However, it remains a hypothesis. It has not been validated on individual patient level. The initial data took only mean values from COAPT and MITRAL and plot them on a graph. So I remain a little bit skeptical. And in another sub-study of MITRAL, which was published by David Messicazetun, we did not identify a subgroup of patients who benefited from MitraClip, even when combining the severity of mitral regurgitation and left ventricular remodeling, which is the spirit of the proportionate MR. So I don't think this is the only way to select patients, and I think we should continue our quest to refine selection criteria.
I agree with that, what you said about the disproportionate, because also the quantification of MR with the methods that we are using, the discussion locally that actually when you really are so, prudent and apply all the criteria, you end up with the numbers that are not realistic. Simply the bias that you are introducing by using the PISA and all the similar factors. So it's not really always easy. And also when you see the COAPT criteria, it was like an algorithm tree. It was error 30%, error 0.4, then it was error 0.223 was different criteria. There was vena contracta, there was refraction. So there was a certain tree that you cannot basically take as a one single measurement.
Joseph, I would like to thank you for this very complex, lecture with so many variables you put inside that. I always appreciated your very balanced, approach to these very sensitive issues, which is some borderline between cardiology and surgery in situation when we cannot easily decide what to do. There's a bunch of variables here, and a lot of time is needed, to crystallize what is the most important before and after the operation to decide and to follow. What is everlasting question for me is that issue of MR2+, because as a surgeons, we never let this MR in the OR, and today in the first lecture, as I remember, we see that MR2+ is connected with decreased survival, and here in results you presented of other studies, MR of 2+ is not a predictor of survival or bad outcome, better to say. It is a lot of work is needed for the whole society to be sure what we are doing and is it really helpful for a patient or not?
Yeah. I fully agree. I think that the discussion will continue. I don't have also the black and white answer.
It's rhetorical, It's
I don't have a black and white answer. I can tell you one thing we have done, but it's very historical. And Martin maybe also can comment on it. We have done the analysis of our series. Again, it's a propagative match scoring, with getting the hard port surgery that was done by Hugo Wannerman and Frank van Praat. And when taking our first experience with the mitral clip, I think 30 versus 60 patients, something like that, what we have seen that indeed FMR at follow-up was always better with the surgery as compared to mitral clip. We have seen that the rates of the mortality of curves of mortality and admissions were sort of going parallel. That's maybe, but it's again, retrospective, small data sets. What is maybe important here to say that in the registry, actually when you think about that, where they are really reporting the mortality benefit, it's very mild dilation. It's a non-index LV volume of 150 milliliters. Okay, it's dilation, but it's not ventricle of 200 milliliters that actually we are treating as well. So it's very hard. You would have to really have a, matching the patient with the same volumes, also not only clinical, also the same volumes to understand whether the residual MR at the given phenotype of the left ventricle, given anatomy and function, what would be the, the impact on the outcome. That could maybe done in the retrospective analysis, but it's very hard to.
I mean, the whole topic of ischemic or functional, let's say ischemic MR is based on papers that are on a very low level of evidence, you know, and it is a huge problem.
But I can tell you from our experience, we look at our data sets on the survivors, non-survivors. Actually, our non-survivors are organic, mainly organic, where they are older, much more remodeled big atria, diabetics, and there we actually could not get the sufficient MR reduction. In the functional, we have a good outcomes. And also we achieve better impact on the reduction. So we have, we have maybe like 70 to 80% residual MR grade 1 in the functional, whereas in the organic, it's maybe 50% grade 1 and 50% grade 2. So that's basically that's why I say we are very, very convinced organic MR, if there is no really prohibitive risk, well, the surgery, and that's definitely like that.
There is also mortality related to the heart failure,
not to the valve.
And we have ARNI and we have SGLT2 inhibitors that they reduce mortality, to a high degree. So we have to re-evaluate in it.
And that makes it much more difficult to have a clean study. And again, I agree, co-opt is actually clean, sterile environment. It's not how we are working. But adding the MUTs, adding the medication, you are doing subtle changes in the biology of the heart failure. That can maybe, kick the remodeling, kick the trend tower improvement by reducing MR maybe moderately, and maybe sufficient enough that the benefit will appear. So it's very hard to get the evidence and to design the trial basically to address this question.
Okay, short question. Thank you for an extraordinary lecture. Just a short question for you as an expert in the field of mitral clip treatment. What would you do in next clinical scenario? If you have CRT non-responder, how long would you wait to treat the patient with mitral clip? We know that we have algorithms for decision trees for that in last position statement, etc. But we know that all CRT responders are not the same. And do you do something beyond the guidelines? Thank you.
It's a very difficult question. We try to reprogram all the time. And also, how long are you going to wait for remodeling or for whatever definition or criteria of the response? 6 months, 3 months, 1 year. We don't have any clear algorithm. We simply do it on the case-by-case basis. I have to be honest with you. We are thinking to make a more like a streamlined process in that. And the thought we have is basically around 6 to 9 months to make evaluation. But again, it's again, as you say, also in your nice paper set, it's always difficult to ascertain when is the time to re-intervene with other device.
Thank you, Josef, very much. So we should move on. Do we have Dr. Salizzoni online? Or? Yes? Stefano, hello. Welcome to Belvis.
Thank you very much.
So it's a pleasure having you, and please continue.
Yeah, I will share my slides.
Yeah, so just to announce, so your topic will be transventricular beating heart mitral valve repair, state of the art and future implications. Okay.
Can you hear me and can you see the slides?
Yes, yes.
Okay, perfect. So first of all, I would really thanks Marco for kindly inviting me. And unfortunately, I was not able to come personally. I will do it next year for sure. I want to come also in Belgrade. I've never been there, so I do really apologize. But with this pandemia, we have to work hard to operate the patient that waits for a long time. So I don't want to lose time to the presentation. So we will speak about the state of the art of transventricular beating heart mitral valve repair and its future implication. My conflict of interests, I'm a proctor of Neocor, and more than this, I'm a cardiac surgeon. So this is a normal mitral valve, a competent mitral valve, the one that every one of us would like to have. And this is what we want to see after a repair, ideally. We start from the Carpentier classification. We know that we have 3 types of regurgitation. I don't want to teach you this, obviously, but it's just to let you know that we have to focus on the type 2. So when we have an abnormal motion of leaflet, and in particular we have prolapse and or flail of the posterior leaflet. We know that prolapse is a common disorder, and there's a prevalence that estimates ranging in the studies between 5 and 15%. Obviously, not all these prolapse cause a severe regurgitation, but a lot of this could become severe and maybe need surgery. And we know from the overview of mitral regurgitation in Europe that actually 1/3 of mitral regurgitation is degenerative. Okay, so we are speaking about a lot of patients in Europe and in the world that suffer for mitral prolapse and mitral regurgitation. And when we have a type 2 patient, 90% of the time, P2 is the most involved segment. And we know from this study from the University of Rome, from Musumeci and all, in which they check and double check that the thing that they saw at the echo was then seen in the operating room. But you can see on 110 patients that the 70% of patients has a P2 prolapse. So this is a classical P2 prolapse. We have a huge regurgitation, a high vena contracta, and this is a nice 3D view in which we can see a chordal rupture and the whole P2 that is involved, while P3 and P1 are okay, and also the anterior leaflet is okay. This patient needs surgery for sure. At least he has less than 3 months of expectancy life because of a tumor or whatever. But probably a patient like this is also very symptomatic. This is again the image I showed you before. And this actually is the 1-year TE follow-up of the previous patient. So of this patient that had Neocor many, many years ago, was one of the first case. And after 1 year, we asked kindly the patient if he could undergo again a transesophageal echo to view the final result. So was quite perfect. And we saw that this patient had a nice long posterior leaflet, but particularly a long anterior leaflet, because coaptation obviously is fundamental for a gut function and of the mitral valve. So with the first result in 2013, the NeoCore device obtained the CE mark. 30 patients, technical success was 95%, and we had at 1 year 75% success without reintervention on the mitral valve. There was just one death, extra cardiac reason. So this is how it works. We have this instrument, this device, that grasps the leaflet under echo guidance, and then you have these fiber optics that tell you when you are in the blood with the open jaws, and when you grasp the leaflet correctly, the four light became white, and so you grasp the leaflet correctly. Then you can pass this 4-0 Goretex suture that is the same we use in surgery, and then we can make a loop and definitely anchor this cord to the mitral. And we will do this for 3-4 times, all the times we need to put a cord on the mitral leaflet. Obviously, one is not enough, because there will be too much strength and pressure, and this may rupture. So we have to put more cord to distribute the force on the leaflet. This is a quick intervention I made in a congress in Germany, just to show you that actually it's easy after a good learning curve. So you enter with your instrument in the posterolateral wall. This is important, not from the apex. And then under TE guidance, you pass the mitral valve. Then the echocardiographer switch to a 3D images, so we can clearly see where we are with our instrument. Here it is, our instrument. Now we are in the lateral commissure. We have to move a little bit more central to grasp the prolapse, that is the central P2. Here is the saddle of the instrument. So we go underneath the leaflet with the saddle, and then we close. You see my hand here. I close the jaws, and then I can insert automatically this cord, and I came out from the ventricle, and then with the 2 purse string, we can assure no bleeding. Then I do the loop. This was the 3rd cord of this intervention, the 3 cord at the minimum requested. And here is very interesting. You see, here we have regurgitation. Now I will pull the 3 cords and look at the pressure. Immediately, the cardiac output changes. This means that not only we have a good, now I release again, you see the cords, regurgitation again, and the pressure down. So not only we have a good result with the echo, but we really give a good service to the patient, because this patient for sure will improve his quality of life and his dyspnea. Okay, you saw there was more than 20 millimeters of mercury of difference when the valve was competent. To have a good result is very important to have a good predicted coaptation, for sure. Okay, if we have a dilated annulus and we have a prolapse, even if we pull down the leaflet, we have no coaptation, so we will have a central regurgitation. And Dr. Colli, who is one of with me, and Dr. Speziali and Robel, who made more NeoCore procedure, invented this very simple tool that he called the LEI. So we will take the measure of the posterior leaflet and the anterior leaflet, and then we will divide to the anteroposterior annus diameter. And if this ratio is more than 1.25, we can assure a good coaptation, usually more than 6 millimeters. If we don't have this good coaptation, predicted coaptation, so less than 1.2 especially, the final result could be nice just at the end of the intervention, but at the follow-up, we will see that we will have a regurgitation again. We know otherwise that with the first cases, we have good result also at midterm follow-up at 5 years, even if we have few patients. There are, I think, as of today, less than 40 patients that could have a 5 years follow-up. And this, for the courtesy of Jörg Sieberger, who made this case in 2010, and this was the follow-up in 2016. And you see, there was no recurrent, just a tiny mitral regurgitation. You can clearly see the neocords here that comes from the posterolateral wall and not from the apex. Okay, this is very important for the good result. So, where are we now with the patient that were already operated with this technique? So, we have more than 1,200 cases all around the world. The majority of these patients were done in Italy and Germany, but now also many patients are done in Asia, in China, in Japan, and we will start soon in South Korea too. And this is one of the most important study with a good numerosity of patients that is a multi-center study, 7 European centers, all patients that were operated between 2013 and July 2017, 265 consecutive patients were included, and we had 190 patients at 1 year clinical and echo follow-up, and at 2 years, 80 patients were eligible for the clinical follow-up and the echo follow-up. Important is this to know that not all patients are the same. And as I told before, it's very important that the patient has the so-called type A anatomy for neocore. So an isolated central posterior leaflet or prolapse or prolapse of P2. When we start operating posterior multi-segment, so also P3 and P2 are involved, we still have nice results, but not so good like type A. When we operate all the other kind of patients, so patients with anterior leaflet prolapse, commissural prolapse, that has calcification and that are classified like type C patients, we don't have very good result. You can see here, so after 2 years, 93% of success with the type A, 74 with type B, and 50% is like to hold it coin, so 50% of success. So it's not really a good result in this kind of anatomy. And if we will see the overall mitral regurgitation in the all groups, we can see that after 2 years, we have a 30% of important regurgitation, so moderate to severe, and while only 67% of mild or trivial regurgitation. These are not good results that cannot justify this kind of intervention. At least, again, you consider only the type A. So if we just see it, the type A patients, you can see that after 2 years, we just have 13% of moderate, not severe, and 87% of mild to trivial regurgitation. So these are good results, quite superimposable to the standard surgery. Here we can have another paper of the group of Vilnius. They made a lot of patients, especially at the beginning of this experience. And again, you can see we have here 90 or 89 patients in this study. And you can see that at 5 years, we have a 79% of success. So 21% of failure, again, is not a good result. But again, if we consider only the type A, we have just 14% of failure and 86% of success after 5 years. And also in their experience, the type B is 84%, so it's quite good. An important thing that they demonstrate in this study that we all know also with the co-op trial and the French MR that we just see, that left ventricle dimension are very important. So in those patients in which we have normal left ventricle size, we have very good results. In those in which we have increased diameters, we have really fair results. And the cutoff is 53 millimeters for women and 59 millimeters for men. And while this is we have to see what is the surgery also, how the surgeon works on the mitral prolapse. So this is a long-term result in mitral valve repair for leaflet prolapse of Tyrone David, so on the Journal of American College. So this is a very important study. And we can see that after 5 years, they had 93% free from the operation and survival. While with the neocore, we had 87. So we are not superimposable, but for sure also the population is different. Here we have all patients, especially young patients, while in the neocore experience, especially at the beginning, were all patients and high-risk patients. So this is what we have as of today. What we can do in the future? For example, can we have different indication, just not to treat the prolapse of the posterior leaflet? Well, Dr. Colli demonstrates the feasibility of a Alfieri stitch and an H2H mitral valve repair with the neocore. It's not an easy procedure for sure, because you need to release the cord exactly at the same level of the anterior leaflet and posterior leaflet, not to destroy the valve and then have regurgitation. But this is very interesting because neocore is more similar to the surgical procedure. So you have less steric endurance compared to Pascal or to mitral clip. Even if we know that as surgeon, the edge-to-edge repair is not really a good technique. This is why we don't use it routinely. Just when we are in trouble and maybe we don't see the anterior leaflet or we don't have a good exposure of the valve. This is another interesting case we made here in Turin, in which we had a really compassionate patient that was denied surgery in other 7 centers in Italy. And this patient has a low ejection fraction. He was a severe BPCO, an ischemic patient, and his operative risk was really very, very high. And he was an EF4 class. He could not sleep and take a shower. And he had an anterior leaflet prolapse of A2, but more than this, he has no predicted coaptation. He had retracted leaflet. So we invented with Dr. Speziali this technique in which we made a pericardial patch, and we used the neocord as a hoising system to attach this patch to the anterior leaflet and to enlarge the posterior leaflet. The final result was not perfect, was a mild to moderate regurgitation, but the patient improved a lot his quality of life, and after 2 years, he was in NIA class 2 and no more rehospitalization for heart failure. This probably would be the future of the neocord procedure. So a combined annuloplasty, transcatheter annuloplasty, and neocord. So in this patient in which we have a prolapse and we don't have sufficient predicted coaptation, we can increase this coaptation just for 4 or 5 millimeters to have a superimposable result as surgery, because in surgery the annuloplasty is mandatory and fundamental. First of all, because you already have the valve exposed, and more than this, because you enlarge your coaptation depth, and this will have very good long-term result. So in those patients that have dilated annulus, this combined technique could be really a nice option. We already made 3 cases in Turin with the carry-on and the neocord with very nice result. I don't have time to show you, but maybe next year we can have more images and follow up. But the things that can change really the future of this technique would be the transcatheter transeptal approach. So neocord is working on this project, and probably first in man could be done in Q1 2022. So it's the same technique. So always the use of cords that are attached to the leaflet and then to the papillary muscle, that for sure is better than the posterolateral wall of the ventricle. Is more physiological, and the cords are shorter and more similar to the length of the native ones. So this probably will improve more than the result we have now, the result of this technique. And this is very interesting, and I really would like to show you next year the first in man, and maybe the first case is done with this technique. So, in conclusion, the neocord is a safe procedure, and there are similar results to surgery in selected patients. Those patients with a type A anatomy for neocord, so just isolated P2 prolapse. And we need good predicted coaptation length and a normal left ventricle dimension. Higher numerosity and longer follow-up for sure are needed to consider neocord at the same level of indication to standard surgery. And finally, device development and technique, especially if we move to a transventricular, to a transeptal approach, will improve result and decrease patient trauma, maybe become the first choice to treat patients with isolated P2 prolapse in the future. I really thank you, and I would leave you with this sentence of Magdi Yacoub, one of the most important surgeons of cardiac surgeon. So to cure the disease, one must recreate the anatomy. And in this sentence, for sure, neocord reflects. Thank you very much.
Dr. Salizzoni, thank you for the wonderful lecture. So now we will
Stefano,
open discussion.
hello. I'm Professor Stojanović from Belgrade. I would like firstly to thank you for this presentation and to congratulate you on entering in something something very new in cardiac surgery. And from that point of view, I completely understood leadership and the number of new techniques as TAVI was born that way. At the time, I was very interested in this technique, and meanwhile, when I saw the results, a huge ethical issue jumped in front of me, and that is how to recruit the patients. Because if you have a very nice surgical, classical surgical repair result for the posterior, isolated posterior leaflet repair with the endoscopic or port access surgery, how difficult is to explain or to perceive a patient to accept this kind of surgery when he's going to see that the results are inferior and less stable than a classic mitral valve surgery. For me, is a huge ethical problem. At the beginning, you know, when you didn't have any results, yes, you're entering in a new field, and as I said, a number of new devices and new techniques developed that way. But now we have results that are not that favorable for the neocore technique. Can you give me an advice or reflect on my comment, please?
Yeah, I totally agree. You know, here in Turin with Professor Rinaldi, we have a very important mini-invasive mitral valve project, and we perform more than 150 isolated mitral valve repair in mini thoracotomy. So I totally agree with your question, also because at the beginning of our experience, we had many failures. The first 5 patients we made, we have a failure at 1 year of 60%. So 3 patients failed. We stopped the program for a couple of years to understand what happened and to see what the other centers made, also because they had better results than us. Actually, we understand that the indication that I show you, so ventricle dimensions, the leaflet coaptation, the anatomy, which part of the leaflet are involved, and moving from a transapical to a posterolateral transventricular approach had improved the numbers. So now we are pretty sure that when we propose this technique to patient, we have a superimposable result to normal surgery, at least at 5 years. And then actually, I have no reason to think why after 5 years this technique should fail if the patient has no problem for 5 years. But actually, indication, at least in Turin, are very restricted. So we reserve this technique in those patients that we consider for high-risk surgery because of reintervention, because of pulmonary disease, because of vascular disease. And we propose to patients older than 70 years old, and we consider the patient that come to us for neocore procedure. And we are very restricted. We just made a couple of, we say, young patients, so like 50, 55 years old, because we want a perfect result with surgery or with neocore. Otherwise, if we continue to use this technique not properly, we will have really bad results. If you want, I just have a couple of more slides, just 3 slides, 2 minutes, to show you that are very interesting for the thing that you told me about the power, about the indication. And you can see again the presentation. Okay, wait a second. Sorry about this, but this I think is really an interesting, okay. Okay, this is a case we made a few months ago. 64 years old male, no comorbidities at all. He, on October 2nd, 2020, at 1 p.m., he has the onset of dyspnea. He has a hypertensive crisis, and he rapidly developed a pulmonary edema. So at 1:30 p.m., he was in the emergency room in a peripheral hospital. And at 2:30 p.m., in need of intubation because PF was less than 100. At 3 o'clock, they had the first contact with our center. And at 5 p.m., patient was transferred to our hospital. This was his X-ray, and he arrived, and in the intensive care unit, we immediately made this transesophageal echo with this pressure. We see the neocorp feasibility, and at 5:50 p.m., he went in the OR. We had also the suspicion of a COVID-19 because of the pulmonary edema of the chest X-ray. So we thought that this microinvasive beating heart procedure could be a nice option with the aim to reduce the inflammatory response and lung injury related to the cardiopulmonary bypass. So we started the procedure at 6:20 p.m. and at 6:45 p.m. we finished the procedure with this result. You can see the posterior leaflet. This is totally strict, and we have a really nice coaptation with the anterior leaflet. This was his chest X-ray, a little bit of effusion here, but this is related to the procedure. And this is the result at the 6 months follow-up. Again, we asked the patient to do a transesophageal echo because he was very happy. I don't know if this will hold forever, but for sure, we made a one-step procedure. If it's okay, the patient has, in 5 days, he was at home and recovered very quickly, because we saw many patients with acute MR after extracorporeal circulation that have many, many pulmonary problems. So if the mitral regurgitation will worsen in the future, we will able to repair again the valve with a mini thoracotomy, because we didn't destroy the valve like with a transcatheter prosthesis or with a mitral clip or a Pascal. If that was sufficient as an answer.
Stefano, thank you very much. Due to the sake of time, we have to move forward. It was enjoyable, and thank you for this wonderful lecture and for wonderful slides and wonderful clips.
Thank you very much. Hope to see you next year.
Oh, okay. Also.
Images, interesting images.
Also.
Okay. Thank you very much.
Thank you very much.
Bye.
Okay, now we are moving forward toward our last but not least presentation. I would ask Professor Deja to give us an insight in surgical treatment on functional MR, when and how. Please.
Let me start with thanking Marco and Sveto for inviting me here. I'm afraid there is no much more data because the topic is very similar to what I had like 2 years ago. So I'm afraid I will be showing quite similar data, and even some slides are probably the same. But as my daughter says, you just preach, then you repeat, and then you reinforce. So I hope you'll, this is some bread for your thoughts anyway. Not this one. So what happened recently is the new guidelines that when you ask me when, in the beginning of this topic, when do you surgically intervene in ischemic or generally secondary mitral regurgitation, moved us quite away from what we were doing like 5 or 7 years ago. I remind you that we were first in the guidelines, European guidelines 2012, we were doing even moderate mitral regurgitation by European definition, which would be like 0.1, I guess, or something like that of ERO. Then we were moving towards only severe, which was like 0.2, and now with these guidelines, we are moving to doing just regurgitant volume of more than 60 and ERO of more than 0.4, even though the guidelines admit that this is not in line with what predicts the survival, is more to make the surgeons not to intervene too acutely on the aortic valve, on the mitral valve. And the only addition here is regurgitant fraction of more than 50%, which is probably softening a bit a message that comes from here. But if I hear correctly, the European guidelines are probably going to move in the same direction as well. And all this comes from 2 trials. One is the CTSNet moderate trial that showed, as you can appreciate, no difference in a reverse remodeling between CABG alone and CABG plus mitral repair in moderate mitral regurg, which was defined by ERO of 0.2. And on the other end, and no difference in survival, but this was obviously not the primary endpoint at 2 years. And on the other end, you have this co-opt trial with a severe mitral regurg that showed sustained benefit at 2 years. And here ERO really was around 0.4, as you can appreciate again. But this completely ignores some other trials, like RHYME trial that showed the benefit of adding mitral repair to CABG in a randomized fashion again, in producing reverse remodeling of the left ventricle, reduced BNP, and the improved exercise capacity of the patients with moderate ischemic mitral regurgitation. It completely ignores data from the STITCH trial that were on moderate and severe, but I remind you that 90% of them were really moderate, not severe. And in this data, this was the survival for medically treated patients, CABG patients, and this was the survival for the patients with the mitral valve repair. And this was statistically significant, and actually the same was shown in so-called hypothesis 2, comparing only surgical patients, again adding mitral valve repair to these patients improved the survival. And this completely ignores the data coming from Duke database that showed that in the reduced ejection fraction patients, adding mitral valve repair to either medical therapy or medical plus revascularization actually was the only factor that improved survival in these patients. Now, to explain the discrepancy between the data, the proportionate and disproportionate concept became very fashionable, but there is clearly something wrong with this data. If you look at this 200 mils of volume here, of left ventricular volume, and ERO of 0.4, and you make a simple calculation that I showed to you 2 years ago already. So this is 200 mils and 30% ejection fraction. This gives you 60 mils of stroke volume. And if you consider ERO 0.4, 60 mils of regurgitant fraction, then these patients are left with no forward stroke volume whatsoever. Obviously, if you take into account the regurgitant fraction of these patients and you just go by 50% of regurgitant fraction, they will at least be left with like 30 mils moving forward, which is more or less 3 mils, 3 liters per minute with 100 beats per minute, which is not much again, but at least may be compatible with survival. So something is clearly wrong with calculations here, and I always thought maybe we just need to move towards either doing CMR or something else. But to make the thing even more complicated, this is the negative trial, the one that moved us away from the moderate CTSNet on this pathway. And this is the positive RHYME trial that should be completely other way around. So it's not explaining much about what we are seeing in a clinical practice. These are the data that I've just found published online a few days ago, comparing both measurements are done by echocardiographies, but this part is based on PISA, and a part of the measurements in the same patients is based on volumetric methods. And you can clearly see that if you use volumetry, which is not very often used because it's quite laborious in echocardiography, you'll find that the volumetric method will clearly give you, will clearly give you smaller volume in comparison with PISA method, smaller ERO, a smaller regurgitant fraction in all the patients. And what's more important, the predictive value of these measurements clearly shows that this is not the PISA method, but the volumetric method that will give you a prediction of improved survival with or decreased survival with ejection, effective orifice area below 0.2, and it will give you worse survival with regurgitant volume below 30 mils, which obviously is a more severe criterion than the one derived from PISA in this situation. So why was a CTS net trial negative? The answer may be very, very simple. In CTS net trial, doing cabbage alone actually cured 70% of patients from mitral regurgitation altogether. If you compare it to 90% of patients being cured with mitral valvoplasty, there is some difference, but it's minute, and it may be the very simple reason that there is no difference. And at the same time, this is a strong argument that cabbage is a very important therapy in ischemic mitral regurgitation, and probably the first line that we should perform. Obviously, you remember that the STITCH trial showed you that performing a cabbage in patients with left ventricular failure will provide improved survival anyway, and it should be done. Another reason for the difference is the volume of the ventricle. If you look at the negative CTS net trial data, then you will see that we are starting with the ventricles of LVSVI around 60-50 mils, and those in the positive RIMA trial are much bigger, similarly to ventricles that are derived from the STITCH trial that are closer again to 70 or 90 of ESVI. Obviously, these populations are completely different. If you look at the mortality and the CTS net trial and COAPT trial, we are dealing with completely different patients and completely different populations. In fact, these patients from COAPT trial are closer to STITCH trial patients than the patients from the CTS net trial. So I showed you this slide last year. This is my, I'm trying to show you my own approach to when I do cabbage and cabbage plus mitroplasty, and there are obviously many papers that you can derive this data from, and for the sake of time I won't go through all of them. My personal kind of approach is that if you have a more severe MR, you obviously opt for mitroplasty with larger ventricles, lower ejection fraction, more dyspnea, less viable myocardium, less contractile reserve, and with the increase of MR on exertion, LV dysynchrony, large mitral annulus, and long time from MI are all the predictors, if you look through different trials, to force you or to persuade you to add mitroplasty to cabbage or to medical therapy, if you like, in patients with non-ischemic mitral regurgitation. Now, another thing that came from the recent American guidelines is that they strongly suggest that you do chordal sparing mitral valve replacement rather than mitral valve repair in patients who are operated for ischemic mitral regurgitation, and this is this nice asterisk that is added to the mitral valve surgery indication here. Now, this again is based on CTS net trial, this time on the severe mitral regurgitation, simply for the reason that there was like 60% of patients having mitral regurg back, 2 years after surgery, a huge number. And at the same time, there was no difference at all in the reverse remodeling between mitral valve repair and mitral valve replacement patients. However, the numbers here are quite strange. If you look at some other papers, yes, we all know that there is mitral valve regurgitation recurrence in secondary mitral regurgitation, but this is probably the longest follow-up that I've seen on the secondary mitral regurgitation repair coming from the Dion's group originally and Jerry Brown group nowadays, showing like 25% of recurrent MR grade 2 or more at 10 years. Okay, this is not ideal, but completely different from what we are seeing in CTS-NET trial. And more importantly, if you look at the CTS-NET trial and you look at those patients who had a mitral repair that hold, so that did not fail, you will see that effective mitral valve plasty resulted in huge reverse remodeling. Obviously, you may argue that this is other way around, that actually the patients who had a good or no adverse remodeling, they had a good result of mitral valve repair, and those who continued to remodel had a relapse of mitral regurgitation. But I would take my chances and say that it might be as well other way around. If you do perfect repair, then you would expect better result. In fact, we know from many trials that the repair and replacement of mitral valve in secondary mitral regurgitation is not completely the same. These are data that are produced from Polish National Registry of Cardiac Surgical Procedures. All secondary mitral valves that were operated in Poland during last 14 years actually. And you could appreciate that if you compare repair with replacement in this cohort, both in crude and after propensity matching, there is some survival benefit of like 25% of those patients who underwent mitral valve repair in comparison with replacement. Now, the benefit obviously is sustained even, you might discuss that there was no mitral valve apparatus sparing in some of these mitral valve replacements. That might be true, but also probably mitral valve repair in vast majority of these patients consisted simply of mitral annuloplasty. And we know nowadays that probably is not an ideal method, and what we do nowadays, we try to add some subvalvular intervention to it. You know, there are many ways of skinning the cat and there are many ways of doing this. The most publicized methods are either papillary muscle approximation, in which you stitch the muscles together, or put a Gore-Tex tube around the muscles at the bottom to approximate papillary muscles, or the methods to reposition or relocate papillary muscles, one described by Krohn initially with pulling the muscles up to the mitral annulus. Another very elegant method of ring plus string is that you put the your anchoring stitches on mitral papillary muscle through aortic orifice, and then you exteriorize the stitches through the aortomitral curtain, and you tie them up under the control of TEE after coming off bypass. So this allows you to position the muscles in the proper position. And all of these methods had some results published. There was a papillary muscle approximation trial that showed that 5 years later there were 27% patients with mitral regurgitation in papillary muscle approximation group and 56% in annuloplasty only group. And this translated to many ventricular factors that actually, or parameters that differed between the groups. These are the data that were just published from a ring and string method, showing that 10 years after this procedure, there is a recurrence of around 25%, and this is the competing risks analysis with the death and remodeling included. And these are the data for papillary muscle relocation, showing that there is a difference of 11% regurgitation versus 3.7 in Fatouche material 5 years later. This is the recent data just on the papillary muscle repositioning coming from the German group, showing very small number of mitral regurg appearing in both ischemic and dilated cardiomyopathy, and some improvement in left ventricular function. And this is just the way we do it. You'll see on the right side the results of a small subgroup of our patients that were just brought back for echo assessment. So this is by no means representative to all the patients, but at least in those that we scanned, we are seeing no recurrence. You just anchor your stitches in the papillary muscle. This is the anterolateral one, and then you bring them through the anterior annulus near the fibrous trigone. This is the posterior papillary muscle with this posterior head, which is reattached to the anterior head to bring those both together. And then again, the anchoring PTFE, this is CV4 stitch, is exteriorized here into the atrium via the anterior annulus near the trigone. And then you add normal annuloplasty and pass the stitches via the prosthetic annulus. So this is to support your stitches. You see we measure 32, so we don't downsize on these situations as much as we would downsize for the normal procedure where you do annuloplasty alone. And now after tying the ring down, you perform the water test, and under this water test we just tie the stitches, bringing the papillary muscles closer to the base of the heart, and you will see particularly with the next one that this will bring all the coaptation line up towards the surgeon, and this remains very, very stable. As you can see from this data, at least in those patients that we monitored, this gives perfect results. This is the patient a month after the procedure. You can see that there is a cord here anchoring the papillary muscle to the base of the heart, and this is a patient 4 years after the procedure, and even though his ventricle is almost 400 mils and diastolic volume, the mitral valve remains competent. And there are some meta-analysis of these sub-annular methods, sub-valvular methods, showing that they may be a good addition to a conventional mitral annuloplasty. This may be particularly important because we know from the literature, this is this Dion's group analysis of 10-year survival, that in those patients who had recurrent mitral regurgitation of 2+ or more, again, whatever 2+ means, the survival was 3 times worse. Now, this slide you've already seen. I haven't shown the group with the dilation of the right ventricle and the left ventricle that Joseph was just showing, but the same might be true about edge-to-edge repair. By the way, what struck me when I looked at the data from this very registry is that the survival of patients with no left ventricular dilation and no right ventricular dysfunction was better than those with left ventricular dilation and right ventricular dysfunction, which is a bit odd. But still, there is, at least in this some subgroup, a difference in survival. And if you remember that with time, TE is prone to giving you some recurrence, then surgical approach with subvalvular repair might be of benefit to the patient. So let me just conclude that I believe surgery is a very, and should be, a very active player in functional mitral regurgitation. First, CABG is an obvious procedure that improves survival in ischemic cardiomyopathy and may cure ischemic mitral regurgitation in at least some patients. Mitral valve repair might improve survival in patients with FMR and LV dysfunction, at least as shown by some trials. And subvalvular repair improves results of surgery for functional mitral regurgitation. That's been shown for sure. And I think we might one day want to perform a randomized trial of TE versus surgical repair and see whether this is comparable or not, because obviously if you can achieve the same without opening the chest, why would you bother? Thank you very much.
Thank you very much, Marek. It was very thoughtful and balanced presentation and very comprehensive. I think we learned a lot, and it's never enough to repeat the wise words. So thank you for that. Thank you for that. So please, discussion, comments.
Do we know the status of the Matterhorn? The enrollment of the Matterhorn, does it still include patients for the FMR versus mitral clip? I mean, the surgery versus mitral clip for FMR?
I am not aware, I don't know.
Because they were a little bit lagging, but they were progressing. I think such trial may have some answers.
Marek, thanks to you for your presentation. It was very surgical. So, I mean, what are we talking here is about, you know, the outcome of mitral valve repair in ischemic valve disease. And the most data we have today are based on technique that is two-dimensional. I mean, that is a reduction annuloplasty. And all the data and all the failures and all the bad results about mitral valve repair in functional MR are based on two-dimensional techniques that are used to fix three-dimensional problems. And without, you know, proper choosing the patient, without experienced surgeon, as I said yesterday, and without intervening in selected patients on subvalvular apparatus, we cannot obtain durable results in ischemic mitral valve, if it is necessary. But this is the surgeon who is going to decide, an experienced surgeon who is going to decide, is it going to work just, you know, with reduction annuloplasty, or you have to, as you did in your presentation, perform something on subvalvular apparatus. And I mean, the surgical experience, if it apply on success of any kind of mitral valve repairs, why is not applying on success of ischemic mitral valve repair, you know? It's very obvious.
I think that the word is a bit more complicated than that. And I simply work on a way that if I have the patient, I take my chances to do the best and maximum we can do with a reasonable risk. So I will do cabbage, we do repair, we possibly do under subvalvular apparatus surgery. But at the same time, I acknowledge we simply don't know whom this operation is going to work on and whom it doesn't work on, and in whom it is necessary, and in whom it can be just, for instance, cabbage instead of doing anything. And clearly, you might, I think proportionate, disproportionate is not explaining the word. At least, I agree that the concept of regurgitant fraction may be more important than the crude volume or ERO only. But this is ventricular disease in the end. And for some reasons, probably some patients will remodel whatever you do. And for some patients, maybe the mitral regurgitation is a playing factor. And if you may abolish it, it will improve survival. My view at the COAPT and mitral FR is that first, I was very happy that COAPT is positive, but because at least it shows that there might be some causative factor in mitral regard that is important, that if you treat it, it will improve the survival in these patients. But the fact that one trial was positive, one was negative, to me, is probably by mere chance. I may be wrong, but they were just more lucky to select the patients that were responders in COAPT trial and less lucky in mitral FR. And the same comes to some surgical trials. In some, we've seen some results, positive results, and in some you didn't. That's all.
Thank you very much, Marek. Any other questions? Thank you very much, Marek. So if there are no questions, I would like to conclude the session. I would like to thank all the speakers the faculty for the discussion. I think we learned a lot today about how and what are the options to treat mitral valve, what are the challenges we are going to face to improve and adopt the therapy for the benefit of patients. And again, I would like to thank Marco and Sveto for bringing us together. And to all of you who were following us, hope you found it interesting, and also teaching perspective for you was beneficial for your clinical practice.
Thank you, Josef. And just to take an opportunity and to thanks to all of you, to our international guests, Professor Iung, Professor Deja, Professor Binder, Professor Vojakovski, Professor Penica, and Professor Bartunek for coming here to Belgrade and making this event special. I also wish to thank our domestic professor, Professor Bilbija, Professor Perić, and on behalf of Professor Putnik and myself, to thank you all, to thank the staff, i da se zahvalim svima koji su gledali i koji su se registrovali i hvala, Professor Stojanović, sorry. I apologize, Professor Stojanović. Hvala svima i sve najbolje.